Well, good morning, everyone. Good morning. Welcome. I'm Lloyd Minor, Dean of Medicine at Stanford. For those of you who are visiting us here at Stanford for the first time, welcome to Stanford Medicine. And for all of you who are here today, thank you very much for joining us today for this symposium on the electronic health record. I've been interested in the topic of the electronic health record for a number of years. And the reason is that EHRs sit at the nexus of two areas that are integral to healthcare. One, in order to realize the full potential to improve the value of healthcare from the data that exists within electronic health records, we have to be able to make those data interoperable and therefore subject to the type of machine learning and artificial intelligence approaches that have transformed so many other sectors of the economy. So that's one reason, is the interoperability focus and need. And then, very closely related and of equal importance, is to use EHRs in a constructive sense to enable and to positively impact the interaction between healthcare providers and patients. And today that interaction is somewhat challenged. We need to, in the very truest sense, be able to have high-tech and high-touch medicine. And to do that, we probably need to rethink the interface between healthcare providers and the electronic health record. Now, I want to say at the outset that we absolutely don't want today, this morning, to be about pointing fingers or trying to assign blame. There's nothing productive to come out of that. And we do want this to be a productive endeavor for everyone. So what we hope will come out of today is some shared knowledge about where we are today and an understanding about the opportunities, and there are many opportunities for the future, and then how we can work together to realize those opportunities so that in the future we have healthcare data that are interoperable and we have an EHR environment that really does enable and empower the type of high-tech, high-touch medicine we know to be possible. And there are lots of reasons for being optimistic. Just this past year, CMS announced a one-year study to address the burden associated with reporting requirements related to compliance. So we're seeing attention devoted by our regulatory agencies on how we can make sure that those regulations for sure promote quality and service, but don't add undue documentation burden. And also, we're seeing countless examples of how already, even within the constraints that exist in the data architectures today, already data are being mined and used to improve the delivery of care. We're not going to solve these problems overnight, but I'm convinced that the solutions are going to require people like all of you in this room together, coming together and thinking creatively about the future and working together to make sure that we address the challenges of today and succeed in meeting the opportunities of tomorrow. It's interesting to remember that it was less than a decade ago that the HITECH Act required that delivery systems and providers transition to electronic health records. And in less than a decade, we've moved from the percentage of medical records, of medical documentation, being in the electronic environment, the percentage being in the low teens a decade ago, now into the high 90s. That's a colossal transformation in a relatively short period of time. So we've moved from paper charts with little colored tabs on the side that all of us who've been around medicine for a while remember, not necessarily fondly, but remember. We've moved from filing cabinets of manila folders, now in some cases to filing cabinets of electronic data. Now for sure, we've already seen many benefits of the electronic health record. I remember when I was in training, for example, I can't even begin to count the number of 2 a.m., 3 a.m. visits that I made with a security guard to the office of a faculty member or the back room of a certain facility in order to track down a chart for a procedure that was being done the next morning. Because, needless to say, many times they didn't make it back to the medical record room. And then also seeing patients in the emergency department with complicated medical histories that you had no idea what that history was, even though they'd received their care in your hospital 4 years before, because the chart couldn't be located. Blessedly, those are times in the past that we don't want to repeat in the future. But we also, I think, collectively realize we haven't been able to fully leverage the power of the data that sits within the electronic health record. So that's an opportunity for the future. So to begin, in preparation for today's symposium, we decided we needed more information. So we collaborated with the Harris poll, and you have the results of that poll at your place, to get information about how primary care physicians perceive the electronic health record. The Harris poll surveyed over 500 primary care physicians in the US. Now there's some initial results that may seem surprising. First, over 63% say that electronic health records have generally led to improved care. Now that's a good sign. So 63% of primary care physicians feel that on the whole, care is better because we have EHRs. And 66% reported being at least somewhat satisfied with the current EHR system that they were using. But as the questions on the survey explored deeper and more complex areas, we noted a number of complexities. We noted that this approval of the EHR was nuanced and that there were many opportunities for improvement moving forward. So here's a snapshot, and again, the detailed results are in the packet that is at your place. 40% of primary care providers find that EHRs bring more challenges than benefits to their ability to provide care to patients. 69% say that EHRs take valuable time away from their patients. 71% say that the EHR contributes greatly to physician burnout, a huge problem in America today. In a variety of different surveys, 50% or more of physicians in practice in the United States today are burned out based upon one or several criteria. Now, by no means am I suggesting that the electronic health record is the only factor accounting for burnout, nor is just, quote, fixing the electronic health record going to solve some very fundamental problems we have in our profession today. But it's certainly a contributing factor that we need to take seriously as we plan for moving forward. 59% of primary care physicians say that electronic medical records need a complete overhaul. And here's some startling results as well. 4 in 10, 40%, say that the primary value of the electronic health record is for storing data. And only 3 in 100 primary care physicians, only 3%, say that the primary value of their electronic health record is to support clinical decisions. 3% feel that the primary value of the EHR is to support them in practicing the very best medicine that they can practice. Now, there's a story here that I want to relay to you. It relates to things that I did earlier in my career. I'm an otolaryngologist. I study inner ear balance problems, and in the 1990s, I saw a group of patients in my clinic who had a bizarre set of symptoms. When they heard loud noises, they got dizzy. And we could even see that their eyes moved when we played loud tones to one ear or the other. And I described this in a paper in 1998, and rapidly people in my field became aware of this syndrome, and we developed a surgical procedure to fix the disorder. It's a disorder caused by bone missing that should cover the top balance canal, the superior semicircular canal. And yet still, because this is not an incredibly common disorder, it's not all that rare, but also not that incredibly common, still, many primary care physicians may see during the course of their practice 1, 2, 3 patients with the disorder. And they may not realize, for example, that when someone comes in and says, when I hear loud noises, I get dizzy, or this bizarre symptom of when patients hear their own eyes move, they have the sensation that when their eyes move, they can hear their eyes moving. They may not realize that this points to that disorder. And so a lot of people then made the diagnosis by simply doing a web-based search using a browser. And this is a picture of Adrian McLeish. He's a French horn player in Germany. ABC Medical Mysteries did a special on him about a decade ago. He diagnosed himself by doing exactly that. He could hear his eyes move, type those words into a search browser, and came up to our websites and papers describing the syndrome. He eventually got referred to me when I was at Johns Hopkins, and we did the surgery to fix it. The point is, he had seen many, many good physicians in Germany, but no one had made the diagnosis. No one had made the link to this disorder. He did, based upon a simple web search. Now, that was a decade ago. But if you fast forward to today and you type into the chief complaint line of a standard EHR today, hear my own eyes move, or noise and dizziness, any of those key phrases, and you as a physician get absolutely no help in making a diagnosis. Still, you would have to go to a web browser, or your patient would have had to do the same thing in order to get on websites or pull up papers that link those symptoms that you may have never heard about before to this specific disorder. We can do better than that. And those are the types of things we need to change moving forward. Now, back to this Harris Poll survey that we did. The average primary care physician, the average of the physicians in this survey, spent 31 minutes in an encounter on behalf of their patients. 12 minutes interacting directly with the patient, and then 8 minutes during that interaction with the patient, but interacting with the medical record. So in other words, the physician focused on the medical record. And then another 11 minutes interacting with the medical record on behalf of that patient after the patient encountered had entered. Now, so what it's saying is that a large proportion of time in the delivery of patient care is being devoted to the EHR. Now, Abraham Verghese, a professor of medicine here, had a wonderful piece in the New York Times Magazine a few months ago saying that we need to get back to the high-touch medicine that brought most of us to being physicians, and that our patients still expect from us. And we need to look at technology as leveraging and making these high-touch interactions between physicians and patients, the type of personal connection that people expect. We need to look at how we can fuel that. And one of the things in Abraham's article that he looked at was the number of keystrokes during an average 10-hour shift of an emergency medicine physician during that shift, the number of keystrokes with an EMR. It turned out to be 4,000 during a 10-hour shift. Now, lest we think that this is all a problem with the electronic health record itself, there was a wonderful study published by Chris Longhurst and colleagues in the Annals of Internal Medicine just recently, showing that the same electronic health record system, namely the EPIC system, when implemented in Melbourne, Australia, and in Singapore, looks very different than an EPIC system implemented in the United States. And that in fact, the note written by a provider documenting a patient encounter was on average 4-fold shorter in those countries than it was in the United States. And that additional 4-fold verbiage in the note in the US oftentimes had little to do with the actual delivery of care to the patient. It was rather to meet the compliance and regulatory related requirements in order to justify billing or any number of other compliance related requirements. And furthermore, their study went on to show that sometimes that extra documentation was related to CMS requirements, but oftentimes it was related to requirements that delivery systems had placed on providers, independent actually of specific billing or documentation requirements. And that's back to what I said at the beginning, that this is not a conference about pointing fingers or assigning blame. It's about how do we get to the root of the problem, and then how do we decide how we move forward in the future so that we can solve the problem and leverage the opportunities that the electronic health record presents. We also ask people, well, what are your short-term and your long-term goals of what you'd like to see in this survey we did with the Harris poll? And here are the results. Short-term, 72% would like to see the EHR interface improved. About half would like to see more data entry transferred to support staff. And 38% would like to see the next generation of voice-enabled technology to assist with documentation. In that regard, we've been pleased here at Stanford Medicine to be, over the past several months, collaborating with teams at Google in order to use Google Scribe to see if Google Scribe can be trained to do the same type of documentation that a human scribe or a care provider is doing in documenting an encounter between a patient and a physician. Long-term, what primary care physicians would like to see, 2/3 of them want us to solve the interoperability problem. They realize that we can dramatically improve the care we deliver to patients if we're better able to derive information from the vast amounts of data that oftentimes sit trapped inside electronic health records. 43% would like to see EHRs support more predictive analysis, and 32% would like to see financial information, such as information about the cost of drugs or services embedded with the EHR so that patients can be more effectively involved in decision-making when there isn't necessarily a clear medical rationale, but there may be financial impacts of one decision over another. So let's get started today. We've got some very interesting panels for you today to start the discussion. Again, the goal of today's conference is to define where we are today, identify the opportunities for the future, and maybe begin to start to form a roadmap about how we succeed in achieving those opportunities. There will be, in terms of a result of the conference and follow-on discussions, there will be a white paper that comes out that leverages the data we gathered from the Harris poll and also what we learned from the discussions today. And we hope that that white paper will catalyze the discussions that lead to the type of transformations enabling EHRs to really fulfill their potential moving forward. It's now my pleasure to introduce the first panel. The first panel is on EHRs in 2028. What should the future look like? Our moderator for this panel is Reed Abelson. Reed is a veteran reporter for the New York Times. She's focused on the financing of healthcare and also how financial incentives can be used to improve the delivery of healthcare. Reed?
Thank you. What I think I'll do is talk for just a few minutes and then invite everybody up. I've been covering healthcare since 2002. That's before the HITECH Act. It's even before the Affordable Care Act. And I've watched from afar, luckily, the evolution of electronic health records. I've seen amazing and profound success at systems that sort of cobble together with outside vendors and others like Kaiser Permanente, Intermountain Health. But I've also seen EHRs become basically billing tools, really where the primary purpose is to allow doctors and hospitals to bill what they would say adequately for their services and what others might think might be more than adequate. But at this point in time, I would say, there really is a universal embrace about health technology, that's significant, and that we all think that technology will help improve healthcare. But I think, as I'm sure all of you do, I get pitched constantly by startups, existing companies talking about the latest app, how technology is going to revolutionize this. And I always remind them that I'm a healthcare reporter, not a technology reporter. And that's not only because I'm a Luddite. It's also because I want to focus on the ends, not the means. Because I think what's important, and I think sometimes gets lost in some of the debate, is what is this doing to affect care? Either for good, we hope, or for bad. But that's really the central question. And really, quite frankly, I would argue that that's the only question we should be asking of all of this technology. And as a subset of that, but as primary, is how does this affect the patient? And my only regret, quite frankly, on this panel of terrific people is that there isn't more patient voices. The other thing I noticed about the panel is how aspirational it was. What should EHRs look like in a decade? And I think while it's important to be aspirational, like all good reporters, I want to ruin everyone's time. And so I'm going to try and instill a little reality. Our view is tempered by the experience that we've all had in the last decade. And what's interesting both about this poll, and I think actually what's interesting, I would argue, about all of the stakeholders, whether it's patients, physicians, nurses, vendors, health systems, is how frustrated they are by the EHR. And the frustration is the fact that the technology doesn't seem to have lived up to its potential. And I think that that's actually just important to remember as we talk about what we should think about in terms of the future. The other, of course, cautionary note I'll raise is sort of the hype surrounding all of this. And I don't have to say anything more than Theranos for you to all understand. But again, I think the focus should be on how EHRs are used now, how well they work, but also, very importantly, will doctors, nurses, and patients be able to take advantage of their capabilities? Because that's an important piece that is often missing. And I take your advice. As much as I like finger pointing, I think it's important to think about the next decade and how not to just end up spending another 10 years pointing fingers about, well, the docs could never do this, the vendors are just crummy, the government is messing us all up. But in fact, think about how do you, in fact, achieve the potential. So now I'll introduce our speakers. First is Dr. Amy Abernethy, and she's the Chief Medical and Chief Scientific Officer at Flatiron Health, a technology company specializing in oncology. And some of her prior fame is a professor of medicine at Duke University, where she also ran, among other things, the Duke Cancer Care Research Program. And please come join me, and then I'll ask you all a question. And then Taylor Davis, the Vice President of Analysis and Strategy at CLASS, who works with providers and is most recently involved in something called the ARCH Collaborative, where he has the unfortunate joy of listening to 100 or more provider organizations all speak genuinely about their concerns. And then Dr. Miner. Now, Lloyd Miner, I would like to say this is the first time I will be able to say someone who needs no introduction. Judy Murphy, the Chief Nursing Officer of IBM Global Healthcare, former Chief Nursing Officer, and among other things, the Deputy National Coordinator at ONC. Dr. Donald Rucker, the National Coordinator of HIT at the Health and Human Services, and also the former Chief Medical Officer at Siemens Healthcare USA. Amy, I'm going to start with you. Isn't that fun? And actually, what I was very impressed by was that you have had a variety of roles. I mean, you're an oncologist, you're a researcher, and you've had some experience with systems outside the U.S., but in Australia. And I think one of the questions I have is, I think one of the concerns about how the EHR has evolved is that, again, its main purpose was billing, I would argue. So looking forward, should the primary goal of the EHR be to have the individual doctor treat an individual patient, or is the primary goal to be able to gather information for research? And do you see those goals in conflict? How do they dovetail?
So as I think about the primary goal for the EHR as a tool in our clinics, really it needs to be a tool that helps us take care of patients. And I think that's sort of this fundamental problem we need to focus on. As a person who sits currently inside of a tech company, I recognize that when we build software for the specs at hand, and the specs have been predominantly around billing. I mean, if you look across the United States, the predominant decision-making around which EHR to purchase was made more at the CFO level than it was with the chief medical officer of an organization. And so, we are seeing a world where software has been built to the specs at hand, and I think it's up to us to envision a different future that's much more around doctors and patients working together and then building that software to solve for it. But I put one point of caution out there, which is that right now doctors are not the ones making the decisions about what systems to buy and what systems to push forward. And so those two things are not in sync.
Okay. Taylor, again, I said you had the joy of listening to all the providers, and what a joy that is, I'm sure. But sorry. But it's really important, again, I think that there is this, like, who's using it, how are they using it, and obviously we've just seen this poll about, again, some of the things that the primary care physicians would like to see. What are you hearing from the folks that you're talking to about what they want from an EHR?
No, that's a great question. I'll talk a little bit louder. God has blessed me with a loud voice. Here we go. So we've had 109 organizations, mostly from the U.S., but 7 outside of the U.S. in the UK, Australia, and Singapore, who have participated in an end-user satisfaction survey that has gone out to all of their independent care providers and oftentimes their nurses. Several organizations who are here today have participated. The bad news is that primary care is the most satisfied specialty of pretty much all the specialties. So we've collected over 20,000 perspectives from independent care providers. The exciting headline that I'm excited to report today is that there's huge variation between organizations. And that is a really, really critical thing to note. Thank you. Sorry about that. Maybe I turned it off. Is that better? There we go. Here we go. I'm sure you can hear me in the back. I know my voice. What's really exciting is that there we go. Yeah. What's really exciting is that there's huge variation between organizations. So while less than half of physicians, and we have almost 20,000 who've responded, less than half of physicians feel that their EMR enables quality care. We've come across a half dozen organizations where their physicians, over 75% of their physicians feel that the EMR enables high quality care. What's really, really interesting is that those organizations are doing very different things than what we thought that they were going to be doing. We thought these were going to be the most technological, the most experienced, the cutting edge organizations. Instead, these are organizations where their physicians highly value their training. They know the limits of their EMR, and they've taken more time than your average organizations in training. These are organizations with high teamwork. And these are organizations where physicians realize that it's a myth that the EMR is going to be intuitive enough that I can just pick it up and use it out of the box. And these are organizations that are realizing that if they have rapid optimization around their EMR, which was the lowest satisfaction area in the Harris poll, that they can really progress very quickly with it. And they are not organizations with high utilizations of voice technology. They're not organizations that are necessarily on the newest version of their EMR. These are not organizations that have some sort of whiz-bang technology solution that are making them successful. They're using change management to get there. So anyway, some very exciting, that's why it's been so exciting and rewarding to listen to these organizations, because we've learned a lot about what is the EMR as we talk about 10 years in the future. What is the profile of a really successful organization? It's not their technology, it's their change management.
That's interesting. Lloyd, I mean, I think you view the potential of EHRs as a way of really sort of changing the way we deliver medicine. And so I'm interested in really what you find most exciting right now. I mean, where do you think we'll see the most change? And I'll note both the time you predicted and what you predict. But
well, I think there are really two areas. One is building upon what Taylor said. It's not just the interface with the EHR, but really rethinking the role of the EHR and how it can be a useful adjunct in the actual care delivery process. And that means in decision support, so that people don't have to remember the symptoms associated with this syndrome that I described, that instantly there's support for providers in making decisions, and that we can really use technology to enable and further the relationship between care providers and patients. That's one area. A second area is that there's a huge amount of data oftentimes trapped within the EHR today, and how can we democratize that data in a way that it can be amenable to the type of AI machine learning approaches that in so many other sectors have yielded transformative impact. And there's an absolute need in medicine today to improve our value, that is better quality for lower cost. And we've already seen in the examples where we have drawn out information from the data that exists, how that process of value enhancement can be furthered by appropriately used EHRs. But I also have the sense we've only scratched the surface, and there's so much more we could be doing. So both in terms of the interaction between care providers and patients, viewing EHRs as adjunctive and contributory in a positive sense of that, and in enabling the type of analytics that we know are going to help to transform value in healthcare today.
Judy, you're next. You've worn also a number of different hats, and I'm interested, you were part of the federal government's efforts to shape the EHR. You've been at health systems trying to actually use the darn thing, and you are now working at IBM. I'm really curious where you see, after what has been really a decade of finger pointing, where do you see the most traction in terms of people working together to actually achieve something?
Yeah, so I think the largest area where I'm seeing traction is using the EHR in more of an ecosystem. In other words, not putting everything in the EHR, but thinking of it as a core tool, but then surrounding it with other systems that might be able to support it. I think the other thing is, you brought it up when you had your opening remarks in terms of, what's the purpose of the EHR really? And we talked about the fact of patient care. So we can't forget that it was the EHR that launched the capability of patient portals. And that has been a huge boon to the way we think about care in the United States, because it has brought patients in. It's not just cracking the door and saying, let's get you engaged in the things we happen to let you get involved in. But in fact, it was engulfing them and saying, we're going to give you your lab results. We're going to let you look at your x-ray results. We're going to open our notes to you. And I think that has done more for that idea that this is about the way we live and not about our episodic encounters in an acute care organization. And that's what I think is the power of the EHR right now.
Dawn, I know you also have industry background, and now you're at HHS. And I'm interested in where you see the federal government, moving ahead to try and make it easier, to make it, EHRs talk to one another, or reduce or increase the regulatory burden, as it may be.
Well, let's see. It's the Trump administration, so increasing the regulatory burden is not on the agenda. It's interesting. So I went into this business to have EHRs do automation, so that, we sort of forget they're actually computers, right? What other industries use computers to make more work for itself? We have a campus, literally built on automation, and yet medicine is the one holdout in a funny kind of way. And so I think the 2028 vision is really sort of enterprise automation, right? Because the real issue in American healthcare is affordability. At least, I think that's, if you went out to the public and asked them, that's the real issue. We are a very labor-intensive operation. I did a study looking at phone calls when I was at Ohio State, and of the 130,000 phone calls a day at that institution, 800-bed health system, roughly half were 60 seconds or less, right? So they're exchanging one fact. Tell me that some large chunk of that's not automatable. So I think we're going to see a very different view of EHRs as really enterprise software, the way you look at an SAP or, pick your favorite vendor here. And so I think that's the real goal too. And that will, most of our things around decision-making in healthcare have been outlier reduction, right? Rules-based expert systems. I was a grad student with Ted Shortliff, literally on the dirt this building was built on. But that's really outlier reduction. And what we really need to do is reduce the central variance of care. So at ONC, we're doing a number of things. Most of them are really under 21st century cures, which was Congress's statement that, hey, we have widespread adoption. We saw the graph, but there's two things that are missing, which, interesting enough, were the short and the long-term priorities in the survey. Short-term, lots of usability problems with this, and has been pointed out, not surprising, you have these documentation tools. I would say we don't have time to get into it here necessarily, but I think there's grounds for optimism on what jointly CMS and ONC are finding, and there will be a formal report as required by Congress on what some of the burdens are. They include documentation, they include the whole world of prior auth, and they include the whole world, the way we do quality measures and the search for value. So I think you're going to see some real progress there from a variety of different approaches and technologies. Interoperability is what ONC spends a lot of energy on. Cures mandates, just folks may know, there's a prohibition against information blocking. Cures mandates a national exchange organization, the Trust Exchange Framework, work in progress. And finally, the most interesting thing, I think, for sort of a tech audience are open APIs without special effort. So having open application programming interfaces, we believe the way it is done in many, many industries is going to change the nature of what's out there, right? If you look at, the Uber Lyft paradigm where you've combined open APIs, you look at travel, you look at banking. In England, all the banks and brokerage houses are forced to have an open API to be able to exchange information. And maybe most spectacularly, you look at retail and the Amazon business model, which is an API model, right? Most of what they sell is actually from third parties. So we think all of those things are going to create an ecosystem that is going to absolutely transform what we have had a very, very narrow vision of up until now in the electronic health record. So throw that out.
Okay. So I want to ask all of you, again, and Judy mentioned sort of the patient portal, but I'm really curious because I do think the role of the patient in the EHR has sort of lagged, right? It's a very passive relationship. I'm not, we could even talk about ownership, who owns the EHR. But I'm curious sort of how you see that evolving. Again, with the focus on the future, what do you hope and what's reasonable to hope for in terms of the patient and the EHR?
Well, I'll jump in. I think we started talking about care teams through this. In other words, again, it's not just the patient-doctor relationship, but it's the patient and the care team. And that's been really successful in the country. Well, part of that team is the patient is a core member of that team and is using shared decision-making and shared care planning. So my idea would be, and lots, I'm not the only one thinking about this, is the care coordination and the plan of care is jointly created using tools like the EHR with the patient and the care team.
If I can jump in here, in a lot of ways, we are approaching the EMR the same way that we are approaching the paper record, which is a huge problem, and is creating a lot of the headlines around the EMR getting in the way of patient care. As we talk to the organizations and then the physicians who are the very most successful with their EMR, they've changed the way that they practice medicine. Let me give you a very small example. A physician that I was speaking to who's very, very successful with their EMR at literally the most successful organization that we've measured said, you know, I watch some colleagues, especially at other organizations, they walk into the room and they have not even looked at the EHR as they sit down and start working with the patient. So of course all of their attention is focused because there's 10 times more information in front of them than there ever has been before. And they're sorting through all of this, and the cognitive load on that is amazing. So you're not going to be able to do that and interact well with the patient at the same time. That's bad medicine in the 21st century. Good medicine in the 21st century is taking 5 minutes before you walk in, going through that cognitive load, understanding what's going on. And this physician said, and look, 75% of the time, I shock the patient with how much I know about him or her. And they are delighted. They feel like that there's a physician who really understands. They walk in the room. And all of us as patients, as we think about that, if your physician walked in the room and understood you really deeply and said, wow, it looks like you've had a sleep study and you're really struggling with sleep apnea and you've been in here for 7 times, we've got to get you taken care of. You'd walk out thinking that you had the most patient-centered care that you had ever had before. And you made no changes to the EMR. All you did was change the way that people approach it. So as we look out 10 years with patient-centered care, we don't need new technology, although we will take it. So EMR vendors out there, thank you. We'll take new technology. We'll take an IBM, thank you. But we can go light years ahead with the current technology that we have as we learn what is 21st century technology, as we leverage the EHR in a very productive way.
So I was going to say something very similar. So to build on that, a lot of this is about workflow. Having EHRs work well for us, whether as patients or as physicians, we've got to have the workflow, and the workflow needs to be as carefully developed as everything else we do. So part of what you were just saying is we need to have read critical facts before we walk in the room. One of the things we studied a lot when I was at Duke was how do we use the EHR as a mechanism to get higher and higher quality data without asking physicians and patients to do more work somewhere. In other words, you know, the EHR should not be a data entry mandate. And one of the things that we learned was it was about designing optimal workflows and teaching people how to do this. And one of the very practical examples is we developed a system to collect electronic patient-reported outcomes at point of care. What we discovered was until we taught the physicians how to do it, it never got used. We made these little cards because what we found was the way to get physicians to use the system well and patients to use the system well was to acknowledge that the doctor looked at what the patient had to say. So we had little cards hung in the rooms and they said, remember to say, I looked at your report and. And what happened was as the doctor said up front, I looked at your report and, it signal to the patient what you've already told me is important to me, and here we're going to go for the next step. So it's a lot about what you just said. You've collated information as a part of your workflow, and you get that information back to the patient.
You know, I think the technology and the sea of technology is actually going to change some of the dynamic, right? Obviously, the EHR has historically been a very, very provider-focused, as we've heard, for the reasons we know, but I think it's actually going to allow consumers to shop. And the products and the services that are going to be offered, I think, are actually going to radically transform. The products and services we've offered to date have really been driven by the physician guild, realistically, and you know the sort of the science we have today. But I think as you look at the future, it's going to be a vastly more information intensive. And there are vast seas of information you could harness right now that would change people's lives far more than much medical care. I mean, one that has always impressed me is a pure computer science play, which is cardiac Ct Angiography. So right now in America, roughly 35–40% of people will die of heart disease. Do folks know that right now there's a technology you can see in every coronary artery whether you have plaque and take care of that and prevent that? Now, in a current non-market, there may be a very fancy list price, but when you think about $1 million computer and $1 million installation and 10 minutes of enterprise time, the real cost of that is $100. That will be digitized. The EMR will be digitized. The services are going to morph. So I think it's going to be very, very exciting to see that. And then some of the more esoteric things, the machine learning, all of that will piggyback off that broader consumer involvement the way it does in other industries. So I think it's going to be very different than an EHR-centric view of the world.
But does that mean, just to follow up, I guess, I mean, and it segues nicely, thank you, to my next question, which is, what, again, going back to basics, what do we expect the EHR to do? I mean, is there a danger that even though we're talking about all of the ecosystem, we want to sort of pile it all on the EHR? And, all of the surveys, et cetera, suggest, burnout, overload. So what's your sense of sort of how we prevent that? Because that's already a tendency, right? I mean, let me sell you, X, not to, again, blame vendors, or let me buy this so I can do X. I mean,
Yeah, let me jump in on this, because it's not as much what we expect the EHR to do. It's what can the EHR and the caregiver do together. Let me give an example. So I flew in here last night on a plane, and almost assuredly, I wasn't up in the cockpit, but most of the flight was done by a computer. That was done because pilots have high trust in the computer in an extremely high-risk situation. They've built that trust up over a long period of time. I landed, I came to my hotel room, I started reviewing some more comments from physicians at an organization that we're about to do a briefing for, and one of the comments was from a physician who said, I can't trust this EHR because it's still asking me to input whether infants are chewing tobacco. That was a real comment last night. Read it from a real physician, right?
Okay.
And so the challenge is today there's clinically stupid things in EHRs that are hurting the trust that clinicians have. Now, where are those coming from? It could be that the EMR vendors are building it bad. It also, but this was actually from the highest satisfaction EMR solution on the market, it could be that the organization has implemented it poorly. It also could be that the physician is using it very poorly and they don't understand that that's where it is. So it's a combination of all three of these factors that come together. So looking out 10 years, we've got to get to a place where we're working on all of these different angles and no one finger blaming, but we're working on all these different angles to build a high trust, cohesive relationship between the EHR and the clinician where they're working together in a really good way. So if pilots didn't trust autopilot, they wouldn't turn it on. And physicians often don't trust their EHR, so they don't use it the same way. And we've got to get to a place where physicians trust their EHR the same way that pilots trust autopilot.
I would also like to say that the EHR, as we think about going towards the future, the fundamental is it's our organizing framework for how do we deliver care longitudinally. The one thing that the EHR always is for each person is at least some version of a longitudinal story. Unfortunately, that longitudinal story doesn't always add up because you might go to different health systems and your story might be trapped in different EHRs right now. But ultimately, it forms that longitudinal story on top of which you can hang all of these other solutions. So rather than thinking of the EHR as an all-encompassing everything that we need to do to take care of every minute detail in a person's health, think of the EHR really as a mechanism to line up the information and then everything else can happen around that.
Yeah, I agree. I think some of our population health systems, our care coordination systems, our home care systems, our telehealth systems are going to augment or create that surrounding the EHR. But the data has to, and that's your organizing framework part, go in and out because there has to, I believe, has to be that home base. And that probably will be the EHR. But again, we all have used that term ecosystem. There will be other systems that will feed it. And the APIs are great. Right now they're mostly reads. The writes are slow in coming, but it has to be both. The reads and the writes so that you are really creating the interoperability that we need.
One thing I'm curious about, because the pilot analogy struck home, and here, I get to be the pessimistic reporter. So if the autopilot had started out perhaps as badly as EHRs, I mean, a whole generation of pilots and maybe another generation of pilots would have just said, hey, forget it. And I know actually in some of the consumer tools are so poor, quite frankly, I'm like, yeah, shopping. Yeah, good luck with that. So where are we in terms of physicians and EHRs? I mean, have we, to what extent is there how hard will it be to, I guess, build trust is my...
Well, I think, especially if we nail some of the interoperability things, which we're pretty confident that there's a series of tools around now to do that. that didn't exist as recently as 10 years ago. I think when you have that, there are going to be more options for getting data in and out of systems, which is really sort of where the frictional cost is sitting. And I think there'll be totally different ways of conceptualizing this. That's the nature of APIs, is they change where the computing and where the interface is. We've been sort of currently bound to relatively monolithic platforms with often extremely old interface and underlying software architectures. As you build out APIs, I think you can have, much more modern environments. And as some of the other things we've piled into EHRs get unplugged, right, as some of the billing documentation, the prior auth, some of the search for value-based care, some of the local constraints, because we've overloaded these systems with all kinds of stuff that has really nothing directly to do with care. The technologies will increasingly allow us to unpack that, in fact, to automate some of that. And then I think you'll see the user experience change materially. And I think some of the vendors are already starting to look at more modern ways of understanding, measuring saccadic eye movements, measuring keystrokes, looking at log files to see, where errors are being generated. Even in sort of the current underlying technology, there are extraordinary tools to dissect out why things are usable and why things aren't usable. Right? You can map out where everybody hangs up on graphically on the screen of an EHR. Right? They're extraordinary tools, and I don't think in general vendors have looked at it that way, but I believe over time folks will do that. So I think there are a lot of ways that we're going to unpack burden.
I'd just like to add that in building trust, I see this on two sides. So at Flatiron Health, we make an electronic health record. So I sort of come at this from one side where I can tell you what generates trust and where we fall down. If you build software and then have releases that are buggy or that slow down care or that otherwise don't meet the needs of the core audience, you'll hear about it right away. And if you have major releases that are buggy, you're gonna erode a lot of trust quickly. And so on the software side, we actually also have to anticipate how important that trust is. And frankly, what I find fascinating is that in the EHR world, the expectations that we would have had in any other technical industry about how we do releases and how we think about release cycles were just not core to the way that we necessarily did it in the EHR world. And I think that we've got the work to do there. But on the physician and patient side, it's quite interesting as well. At Duke, we had a program which we called the Learning Health Systems Training Program. We were trying to figure out how do we train the physician of the future and what we saw is that younger physicians already trust the ecosystem in a totally different way because they know how to maneuver in it. And frankly, they know how to crowdsource where the warts are so that they can start to be a part of the fix. And so I think we need to think about the physician of tomorrow and harness that energy. Bring some of that into everyday medicine right now, but also anticipate the physicians of tomorrow are going to be different and know how to trust the system and make it work for them differently. And patients of tomorrow are the same. They're going to make it work for themselves differently too.
And if I can build on what Amy's saying, I think a really critical thing is I trust what I understand.
Right.
So if I was getting on a plane, and I'm kind of a nervous flyer anyway, so if I was getting on a plane and I heard a pilot say, "Stupid computer system, it's not my job to know how to use this computer system," I'd turn around and walk back out off the plane, right? The challenge is that, and this is an unpopular thing to say, is that it is common clinical culture today that it is not my job to understand how this computer system works. The challenge is, and frankly, most organizations require less than 4 hours of training for new physicians on enterprise software. And enterprise software in every other industry, as you talk about, requires a lot of education to understand its limits. And we're going to need to know those limits even more into the future so that I know whether or not my EMR is going to help me with a diagnosis of hearing my eyeballs move, or should I not expect it to help me there? I need to know what those limits are, and I need to understand those. And that's going to take some investment from the clinical community and from provider organizations to make that available for their clinicians to be able to really understand what they can expect and what they can't expect if we want to get to the point where the EHR is a counselor to us in our care.
I also have to comment on consumerism, just to jump on that. 10 years from now, I'm not exactly sure what we are all going to expect from our health systems, but I'm pretty sure it's going to be different than what we expect today. We're not going to walk into a hospital not knowing how long we're going to be there, how much it's going to cost, who's going to touch us, when we're going to get a chance to leave and go anyway. I mean, what other aspects of our lives do we do that kind of stuff? Nowhere. And so our experiences in healthcare are going to be colored by our experiences in purchasing retail on Amazon or taking a ride with Uber. And people are starting already to say, I don't understand why you don't have my allergies. I don't understand why you don't know about that thing that I'd had taken care of across the street. So that's going to be pushing all this. It's just another momentum.
Right. So now I get to ask the happy question, which is, so what are you most excited about as you look forward?
Well, I think from an ONC point of view, one of the things that's really most exciting, the thing that's most exciting with the open APIs without special effort, which means you have to use an industry stack, right? You can't just make function calls to your EMR and say, hey, it's an open API, right? You need to use standards. Is the rapid evolution of FHIR, and within that, all of the large payers have gotten together and a number of others, including HL7, and we're jointly building out population-level FHIR standards. So everybody talks about big data, and you can talk about big data till you're blue in the face, and I'm sure in this campus people have. But it's nothing without actually getting the data, right? You do actually need the data to have big data. And right now, we do not have any operational interfaces to hold institutional providers accountable for care. You can either curate a contract with quality measures, narrowly defined, or you can do one-off queries into the database. There is no API-based way of really understanding who's doing what in American healthcare. And population-level FHIR, I think you may hear from Anish Chopra here a little bit later today, I believe. But, whether you call it that, bulk data, flat FHIR, all the same thing. That, I think, is going to be transformative, because then across providers, not just within providers, which is the big data today, or the very narrowly curated sets, we're actually going to know what's going on. I believe that in and of itself will be powerful.
Go ahead.
I thought we were going in a row. We don't have to.
Oh, no.
Power of the patient. That's been my theme here, and I feel very strongly if we're going to change the culture, if we're going to change the health and wellness of those of us that live in the United States, it's going to be about that patient involvement. And these are tools to do that, and that is the only way. My blood pressure is going to be my problem and not my doctor's problem. And my propensity for diabetes is my problem and not my doctor's problem. And I think that's going to be core to where we need to go in the next 10 years.
I agree with the things that have been said. Makes me think about cars. Cars were invented in the late 1800s, but the potential was really unlocked over 50 years later with the interstate freeway and highway system. So we've got great technology. And I'm so excited to see it get unlocked, and we're going to figure it out. We're going to figure out that we need roads and cars. We're going to figure out that we have to do things a little bit differently with these. And when we figure that out, healthcare is going to make the shift that we were all hoping it was going to make in the last 10 years, but it is going to make this shift with lower cost, higher quality, and frankly, better clinician satisfaction.
So I'm excited about the fact that as we put this together, we're going to have data that really give us answers that we need. It's, we can think about a whole bunch of different ways that we get there in terms of data aggregation and interoperability. But when that happens, what we can see is, really powerful. One of the things we've been studying at FHIR is something that I call time to insight. How long does it take to answer critical questions? It used to take us, say, 14 to 17 years to go from clinical trials to ultimately widespread use. We're now seeing things shrink to 18 months, and we're able to follow the patterns of care across the country and then get that information back to doctors. And what I'm seeing is that as the physicians and patients see the power of that information, they actually want to participate and get that better.
I would just echo what Judy said, power of the patient. I would take it perhaps one step further to say power of people, patients, and also healthcare providers that I think we can dramatically improve health in America and the world if we leverage EHRs to achieve what we, I think, inherently know they can achieve in enabling more effective interactions between people and healthcare delivery systems and enabling all of us to really be focused on value-based care because we're armed with the data to understand what we need to do to achieve better value in healthcare.
Well, thank you, everyone. This was great. And now it's my pleasure to introduce the next moderator as we leave Dr. Christopher Sharp, the Chief Medical Information Officer at Stanford Healthcare.
Good morning. I'll start with a full volume. Okay, great. Thank you. That doesn't sound much different to me.
Okay.
Okay. Thank you. Good morning, everyone. I'm Christopher Sharp, Topher Sharp here at Stanford Healthcare. Really a pleasure to be moderating the panel. And I love technology. So I'm one of the key reasons that I've been active in this. I'll also sit here. Thank you. And so our next segment is to talk about the concept of removing friction out of the user experience in the interaction with electronic health records. And I'll introduce our panel in just a moment and have everyone come up. Let me just take a moment as well as Reed Abelson did just to briefly express an intro to this. As a practicing physician, about 10 years ago, I had the opportunity when we realized that we had an awful lot of paper records sitting in our midst as well to look at how we could mature and change our environment. And a big part of what I took on in my role was adoption. And we called it driving adoption, which if you think about it is sort of an unusual place to be, right? Try to tell a lot of physicians, a lot of expert professionals that what we're going to do, you want to adopt this, and in fact, we're really going to find a way that you will in order to bring you forward into the future. One could imagine that as you go through that experience, you'll generate friction. You'll rub up against the friction of that change. Today, we're in a very different place where we have many, many organizations across the country that are relatively mature in that implementation phase, and now we're moving on to this next phase of optimization and really building out ways to fulfill the promise of the EHR in order to support the care that their physicians engage and deliver, and their clinicians and their patients would like to see as a part of their environment. So where the first panel was looking to the future, we're going to look very much to the present today, talk about what that experience is like and where we can go as we look forward. With that, I want to introduce our panel of terrific speakers here. First is Roy Beveridge. Roy, please come on up. Roy is the Chief Medical Officer for Humana. He is there, haven't quite figured out where I stand here. Roy there is works as foundationally implementing clinical strategies, integrating care delivery models, and working on physician community models. Roy has previously practiced greater than 20 years in oncology, was the EVP and CMO for US Oncology, and then moved on to the CMO at McKesson Specialty Health, so brings a very diverse background. Next, I'd like to introduce Kimber Lockhart. Come on up, Kimber. Thank you. Kimber is the Chief Technology Officer at One Medical, where she brings her engineering and computer science background, in fact, a BS right here at Stanford, to the operating work of One Medical. She's been a director of engineering at Box and a co-founder of Increo as a startup that was later acquired at Box. Next, I'd like to introduce Chris Sinski. Dr. Sinsky is the VP of Professional Satisfaction at the American Medical Association, has been working to promote high-performing practices and physician wellness, including some terrific work with the ABM Foundation looking at high-performing practices, and is also a practicing physician. Next, Josh Holzbauer. Josh is the Director of Physician Wellbeing at Epic Systems, and his work is to optimize the physician experience, assure alignment with clinical needs. Josh brings more than 10 years of implementation and optimization experience to his work. And last, Eric Kins. Eric is the Chief Innovation Officer at Allscripts, where he is doing some very innovative work around open APIs and has created what is called an open business unit, which is fostering a development community around Allscripts called the Allscripts Developer Program. So welcome, panel.
Thank you.
Well, we're going to start in here with a little bit of a general question here, and just to note that as long as EHRs have existed, I think it's fair to say that we have had some challenges with the end user experience and always work to do around that. Maybe what we could do is just work through the panel, have each of you just briefly speak to your background and whether you think we're really actually getting any better in our user experience. Eric, can you start?
Sure. Thanks. So real quickly about my background, I've been with Allscripts since 1999 as part of an acquisition of a small company that was doing e-prescribing in '98, which was pretty early on. What I'm going to say, I sometimes like to speak in analogies. I think it kind of fits pretty well. I think what we've all sort of collectively as an industry have built is a shovel. Now let me get to that. And as I was sort of putting together this analogy, it occurred to me that a lot of the large EHR companies are based in the Midwest, some in the Boston area. These are like snow belts. So the analogy is we've given providers the task of clearing a driveway of snow, okay? And so we get some EHR developers in there and we come up with a shovel. And it's a straight pole with a flat shovel on it, a metal handle. And we gave it to the doctors to clear the snow off of the driveway. And they started using it as, it's okay, but their backs hurt and it took a long time. And so we brought in some user-centered design shovel people to work with these providers to fix this shovel and make it a better shovel. And so we have an ergonomic handle, we have a foam thing on it, maybe a deeper bowl, maybe it's got a metal thing to scrape the ice on it. And the feedback came back, hey, this shovel's really, it's a lot better than the first shovel. But the problem is the task wasn't to shovel the snow off of the driveway, it was to clear the snow off the driveway. So in fact, what the providers needed was not a shovel at all, but a snowblower, or perhaps heated driveways, right, to clear the snow completely off. So I think that is sort of, as an industry, what we've done was it was mentioned earlier that we've taken the paper records and we've turned them into a digital version of that. And in fact, the user, the way that we interact with those systems is still using that mind. So I think we're still where we've come a long way, but I think we're still not there yet.
Okay, well, we need better shovels. Josh, if you could talk a little bit about the same here, just
Sure.
Are we getting better?
Sure. One thing about shovels, so I'm from the great North Woods of Wisconsin, so I have a lot of shovel experience in my life, and I was just having palpitations thinking about, wait, is there snow coming? Even though it's June. 3 weeks ago, it snowed in Wisconsin. We got about 6 inches in Madison, and so, sorry, I just gonna think that one through. Okay, so to your question, Topher, are we getting better? Absolutely, I think that we are in a number of different areas. I'll try to keep it relatively broad, but the first one would be with patient engagement. Someone on the last panel had mentioned the advent of the patient portal and how patients are now able to not just receive information, but also share information back with healthcare organizations. And specifically with the advent of telemedicine, they can interact with their care team in new and innovative ways. I think that another area that's been important is, of course, interoperability, and we are making strides there. Just within the last year or so, we've introduced a platform so that not just can you see information from other EHRs in this separate place that you have to go to, but we can actually intermingle that information right along with the information that you have from your own EHR. So as much as possible, we're looking to do more of that. Right now we have that for things like progress notes and encounters, but in the very near future, we're hoping to expand that to labs and radiology. So those are two big areas, and I think the last one would be predictive analytics, and I think we're just scratching the surface on this one. I'll just talk about what's out there today. We do certainly have, at Epic, we have a number of risk models for this, things like risk of readmission, risk of sepsis. We try to bring it to the point of care, put it in the physician's workflow so that they can see these things. I hear a lot, and I'm sure the other people on the panel here too, that clinicians are asked to spend a fair amount of time entering this information into the system, and they're looking for that payoff on the back end of, okay, I've done this work now show me the smarts behind this, show me how it can impact how I take care of my patients. So those are the positives that I see out there, while recognizing we all have a lot of work to do.
Chris?
So Topher, thank you. I am a practicing general internist in Dubuque, Iowa. I've used one EHR for 12 years, and then for the past 4 years have used a second EHR. Both have been major, widely used EHRs. And I have to say, from a personal experience, my personal experience has actually just gotten harder and harder over that period of 16 years. Not because the EHRs have changed, but because the expectations of use, the expectations that every act must go through the EHR, that we translate the clinical experience into digital data for the convenience of others, and not for advancing clinical care. Those pressures have increased. Nonetheless, I am optimistic because I think we've got greater awareness now about what's going on and what we need. And to carry on that transportation theme that was started, I think we're starting to understand the importance of a manageable cockpit. That physicians currently and other users are suffering information chaos and information overload. And what we need to do is model after the airline industry, where a group of engineers studiously determines whether or not a new light, a new warning, a new buzzer is warranted within that cockpit. And lots of things that might incrementally appear to be beneficial are not brought into the cockpit because cumulatively they add to the cognitive workload. So my optimism is that as we start to now understand the importance of the cognitive workload cost, and we recognize the importance of a manageable cockpit, we will design, implement, and regulate differently.
Thank you. Kimber, you are in a company that has taken a fairly fresh look at healthcare delivery. When you look at the way in which the EHR interrelates, do you look at that and think, boy, things are looking up, things are getting better here?
Well, for those of you who are not familiar with One Medical, we are a primary care organization. We have about 75 offices across 8 markets, and we're rapidly growing. We also have made the decision to develop our EHR in-house. So my team is responsible for the development of that EHR. I think in general as an industry though, and even within the EHR that we develop at One Medical, we have a bit of a whack-a-mole problem. We solve one issue that we're seeing, and we create an issue somewhere else. And I'm optimistic that we are moving in the right direction, but it's slow and it's not direct progress. One of the things that concerns me the most when we talk about sort of provider experience around EHRs, a lot of the focus is on the right side. It's around data entry and getting information into the EHR. There's been a lot of really interesting innovation in that space, but that's only part of the equation. As the last panel discussed, the process of understanding at a glance what's going on with a patient is incredibly important. You shouldn't have to go in to read the chart 5 minutes before. It should take 30 seconds or a minute to understand the most recent context for the patient. So when we think about provider usability and provider experience in the EHR, we try to balance across making it easy to enter data, but also realizing there's another side of the coin. And sometimes by making data easy to enter, we have 4 times or 10 times as much data as we need, which then makes actually understanding that data even harder.
Great. Roy, please give us your perspective. You come at a fairly different vantage point now.
Sure. So I practiced medicine for 20 years taking care of oncology patients. And in my present role as CMO for a large national payer, the one thing that I've learned in terms of trying to answer the question you posed is, who are you talking about? And so if you talk about primary care physicians in fee-for-service right now, by and large, they're supportive of improvements that have occurred and think largely that things have gotten better. If you talk to primary care physicians who are in risk arrangements, and remember that's becoming an increasingly large number of people, and if you think about primary care physicians who now start taking care of all of Medicare patients, where everyone's moving into that risk pool, they realize that things are not as rosy because the infrastructure they're using is a fee-for-service tool built on a paper system. So it's a paper system that was developed for fee-for-service, which was then transformed into a data collection system for fee-for-service, which is now being used for a value relationship, and it's wildly challenging for those folks. And if you then look at different specialists, the dermatologists look at you and say, I need a system for looking at pictures and advancing things forward. And if you speak to the oncologists, they're asking for an analytic unit that's built in as a decision support tool for understanding what types of therapy they should be giving for their patients. So I think that for some folks, it's probably improving. I think for a lot of other physicians, it's probably not.
Can we build on this? Because I think when you read kind of common editorials, a very common statement is that EHRs are built as a billing enablement tool and not necessarily a clinical care enablement tool. I think we've all kind of heard this referenced, and it's a fairly easy passing statement to say. How true is that, and what would we need to do in order to change that? Chris?
So I think if we sort of unpack that statement that you've just made, what I hear is this transition that I've observed, that we have moved to, thank you. I think we have a very transactional notion of the concept of healthcare, and that our infrastructures are built on that transactional notion, and that our billing system is based on that, our EHR design in some ways is based on that, and yet I think where the value comes for our patients as well as for our payers and for our providers is in the relational aspect of care. And that our tools need to be modified so that they support the relational aspect of care, the relational notion of what healthcare is. And in very practical terms, that would mean that it would take 30 seconds to get situational awareness, because I'd see the picture, I'd see the family, I would know the incidental social history immediately, and then I would see all the relevant data and then could take action all in the same screen, because that would allow me to have that relationship be supported.
I was just going to say, just to echo what I heard during the first session as well, that for the folks who work very, very hard to develop these products, we're largely doing it based on client requests from the beginning to right now. So the groups that are our clients that are part of the community over the years, they've requested a certain type of product, and it reflects the water that we all swim in this industry. And for better or worse right now, a lot of physicians out there and advanced care practitioners are still living in kind of two worlds between fee-for-service and value-based contracts and risk-based contracts. And there's a lot of information that ends up in the notes here in the United States that physicians here have to do that you don't see abroad. And just to make another reference to that study that was published by someone in this audience, Chris Longhurst, pointing out that abroad the notes tend to be 3 to 4 times longer than the notes here in the United States. So, but to get on a more positive note, in the last 5 years, we're hearing different requests. We're getting pushed, and rightfully so, into a more holistic record, into making it more about the experience between the physician and the patient, and taking into account things like social determinants of health, genomic data, to give the physicians a more full, holistic picture of their patients.
Well, may I probe this a little bit and ask then, how much do we need the EHR to do all of this? How much have we kind of closed up the shop around the EHR and really all looked to the EHR to enable these other elements that we're referencing? And Eric, I'm wondering with your experience.
Sure. So I think a couple things, and just to sort of dovetail off of what Josh was saying, just with sort of from the EHR development perspective, right? Our input is largely it's client requests and client committed enhancements and things like that, and then regulatory. And I think that we all kind of feel like the first couple iterations of meaningful use were pretty strong-armed, and you need to implement these things, and they have to be implemented this way in order to get reimbursed. And so we all sort of did that, right? And I think the ONC has been very helpful and collaborative in sort of, well, how do we do this moving forward so it's not so prescriptive, so that there's more freedom for the vendors to differentiate on how they go about implementing these particular items that need to be measured. So that's, I think, a lot of where that sort of billing side comes in. And I call it a double-edged sword because it was exactly those acts and the HITECH Act that helped us explode this thing and go from paper to digital, not without its problems. So, and then with respect to some of the newer data sets that are coming in, right, and the responsibility of the clinician to now all of a sudden know about the social determinants of health and know what zip code you're in, know that the smog levels there are bad. I mean, that's a lot of new data that have to be consumed. So, in my mind, again, I think my heritage has been on building an open API toolkit. This was 10 years ago. And now with the advent of FHIR and Argonaut and the Karen Alliance and all these other consortia that are out there that are building, looking for ways that we standardize these APIs across all systems, which then, of course, opens up the ecosystem to every developer that's out there. So you're not just developing to one particular one particular system. So in my mind, by having an ecosystem where you can actually snap things in, so that if I'm a nurse and all I do all day is intake, right? It's kind of the Swiss Army approach. I have one tool that I need to use. It's this small little app that all it does is collects vitals and whatever else I have to do, and that's all it does. There's fewer lines of code. It's not as complicated. You can release it more frequently. It's not this huge burden for large organizations to take on. So I think that app culture is something that's going to be very, very helpful. And just as a final sort of color piece, there used to be this kind of joke that any client that paid us $1 million got to say that they wanted a new button and they get to put it somewhere. And the problem with that was over time, we had 700 different user options in one of our pieces of software. So that is 2 to the 700 possible different combinations of configuration. That's more different options than there are grains of sand on Earth. There's no possible way to test that. So we need to simplify the number of lines of code that we have in these applications, make them smaller, keep the EHR as a repository for the data, and build on top of it. Because I think it's the monolith it's too much.
It also sounds like those who are requesting may be their own worst enemies around this. And sure. When I think of sort of how you save us from ourselves, I also think, getting back to this billing concept, I'm a primary care doctor, and I have to work through pre-authorizations and other, steps that I see as fairly clerical as related to my clinical work and training. Maybe Roy, could I ask you to speak a little to, what would we do today in order to really continue to nudge this in a different direction than it is?
Well, I feel really sorry for the primary care physician who is living in both this very transactional world and into the world of value. So if they're in the fee-for-service world, they have to tick off 7 review of systems in order to get paid. Yet if they've got a patient who is a diabetic in a value world, what they're really interested in is not those review of systems, because there's not a lot of value there. The value is, did the person actually pick up their insulin or their diabetes medicine, and do you think they took it? And so because of this, because of the way people are being paid, you're changing people's views on what's important. And what's really important is on the value side in terms of the end result for that patient. And so, you know, we are in this terribly unpleasant this time in between payment methodologies where we know that in 10 years, we're all going to be on a value type risk event. Whereas right now, you know, it's half and half or 70-30 or something. And it's painful for all folks. What the payer world wants to see is a much more frictionless system. There is no reason that, in effect, in a value world, that, you know, we need to see a whole lot of stuff. What we're looking for are the end results, and then there shouldn't be all the pre-authorizations that you just spoke of. If you are in a risk relationship, and however you want to define that, you, the physician, you, the entity, should have the ability to do that which you were trained to do without having a whole bunch of mother may-I's. And systems that work well should be able to do that.
May I ask, Kimber, you work in a model that I think has a fairly different incentive structure. Does that sort of open up the options for you? You've said there are still trade-offs. How does that work?
I actually agree with Roy here. It makes it harder to support multiple models of reimbursement at once. That being said, this is not unique to healthcare. Across all industries, what you get paid for shows up in the software. And the more that we can plan for that and abstract out the complexity from the software interface as we design it, the better we end up. So trying to pretend that that's not a real dynamic is going to get in our way. The other thing I would say is that there's a couple other options we have. So either we get together and we adjust what is required in order to be able to bill more simply, or we'd be willing to walk away as systems from some incremental revenue in favor of keeping the provider and patient experience what it should be. Now, there's not a lot of health systems, as it turns out, lining up to walk away from some incremental revenue, but we do have options here. And I think that, that ultimately, many systems right now are in sort of the worst of possible options, which is that we need to have these billing controls in the EHR. We threw them in there quickly, and we haven't taken the time and effort that it takes in order to truly abstract out the complexity of using those controls.
If there's just one thing I could add to that, it would be that for those physicians that Roy mentioned that are having to live in both worlds, this is one area where I don't see this being resolved anytime soon. I think that even if just 5% of your patients are Medicaid patients, as a physician, you still have to know all the Byzantine rules that go into that. And likewise for the value-based contracts and a number of other payers. You have to know all those rules, and then when you get out there, and I'm teeing Chris up or something. I don't know if you saw it coming. But so when I'm out there, and a lot of what I do over the past 13 years is I sit in exam rooms, I shadow patients as they go through outpatient clinics, and what you see is the physicians, every time that patient comes in there, they're taking a look at, okay, who's the payer, and what's covered, what's not covered, what are the rules here, and what tends to happen is they fall back on the most restrictive information that was given to them, the most conservative take on things, because they want to protect themselves for obvious reasons. And because of that, they end up, even in cases where they don't need to, they end up doing things that aren't necessarily required for that patient, but they'd rather just say, hey, regardless of who the payer is or what the situation is, I know if I do it this way, I won't, the charge is going to get approved and I'm not going to get sued later, so that's what's going to happen. And teeing up for Chris, I think the term that you've coined for this is regulatory confusion, and we see that, I personally see that in nearly every clinic that I visit.
Chris,
I'll
you
just
wanna take that?
respond to that briefly. I think we have a tremendous opportunity to debunk some of the urban myths and reduce regulatory pain points around some of the well-intended regulatory efforts. And if we can start to provide some clarity, we can identify more efficient pathways. And I'll just put a personal example on this. I just learned that at one of the universities in my region, nurses can no longer renew and reauthorize medications. That has to go through the physician at that organization. So someone at that organization, likely in the compliance office, became very fearful of failing an audit. And the end result is a more hazardous environment for patients. And we have to start connecting the dots across that and start to clarify some of that regulatory confusion that currently I think is adding so much sludge to the gears of healthcare.
We have such a huge opportunity around regulatory confusion, though, in adding more of the context into the EHR. So imagine if the EHR knows and the provider trusts the EHR's knowledge, so to speak, of what needs to happen with any given patient, given their payer environment and so on. So I think actually EHRs have a tremendous potential to cut through some of the complexity of regulation. And I don't think the complexity of regulation is going anywhere anytime soon, so we need to equip our EHRs to be able to handle that.
So, you know, one thing that would get rid of a lot of the complexity is the work that the federal government and others are doing around interoperability. If we truly had an interoperable world, then a lot of the stuff that we're just talking about would happen instantaneously. So for instance, if Humana or any other payer were connected truly in an interoperable way with a clinic, with a physician, there's no reason that as one is ordering prescription A, that it doesn't go immediately to the formulary and come back with an authorization that happens instantaneously. It exists now. We all have products that do it, but because of this lack of interoperability, you don't have this immediate feedback loop that occurs, and it happens really instantaneously. There's no reason that we have all of this friction that we have in the system. And so, you know, it's the EHR as itself is pretty good, but I think when people were using the examples of the roads and things like that, that was a great analogy. We've got to have the interoperability to allow these analytic units, these bits of information to flow effortlessly back and forth. Once again, I'll say it, a lot of this stuff already exists. It's the highways that aren't in place to allow this ability for the physician to work efficiently at this point.
So the argument has been made that the HITECH Act and meaningful use in many ways propelled us forward into a digital age, but at the same time may have distracted us from opportunities for innovative ways of delivering care as we progressed against basically check boxes to assure that we've meet all of those current types of requirements. And while we've heard about, as Dr. Rucker talked about, some of the changes that are afoot currently, I'm wondering, you know, thinking near term, what can or should we be doing in terms of innovations, in terms of advocacy, and really trying to open up so we get more attention, essentially, Roy, put on the places that you're describing and less attention perhaps put on the places that we've been doing for some time. Eric, you want to kick us in?
So for short term, again, I think we need to build on what we've already done with sort of the open APIs, FHIR, which is still early on from an adoption perspective, but places like Apple and Karen, and like I mentioned before, you know, these third parties are really pushing the standard ahead. And so that gives us the data connectivity layer. What's missing there is the workflow layer. So it's important for us as vendors to make sure that we're supporting also industry standard workflow integrations like Smart on FHIR or CDS hooks, for instance, right, that are standardized, because there are far more smart people, developers, outside of the core EHRs than there are inside the core EHR. So we get to iterate on those faster, and it goes back to those smaller lines of code, little snap-ins, and we get to be more like your telephone where you get to pick what you want and how it works. I think that creates some of that fluidity and enhances the user experience for end users.
If I could just expand on that, one of the most important things here is that the interfaces we design from an interoperability perspective are developer-friendly and reliable. We saw huge changes in the payments industry between PayPal being a dominant processor and the move to Stripe. The move to Stripe was largely perpetuated by the fact that Stripe's interface was more developer-friendly. And it's actually brought a lot of business and of traffic over to Stripe. And so I think it's easy to kind of even check the boxes on, do we have the interfaces to do these integrations, and forget that the easier we can make it to do those integrations, the more we can rely on the innovation of our entire ecosystem. Just as a quick side note, we did an integration with a to be unnamed healthcare vendor a couple of months ago, and needed to go back to that integration on multiple occasions. We were getting all of these errors. It turns out that their API's uptime was abysmal. And of course we had a contract with them saying that the uptime would be 99.999 or whatever we requested that it would be. But they were flubbing this connection over and over again. So we actually had to go back and put significantly more effort into the retries around this particular set of logic. All that is to say, if it doesn't work well, then the incentive is not going to be on the organizations to actually do that integration, and that's too bad. Because I think as an industry, we have to be able to leverage the effort of all of these small solutions across healthcare.
I'll just call it a local example for us in California recently was the implementation of an act called AB 40. AB 40 says that when you're prescribing a controlled substance, you must reference the PDMP database in order to check whether prescribed controlled substances have been prescribed for the patient. And what we've been finding in that interaction is that the law was written in a way that does not really allow the highest state of standards-based interoperability and innovative technologies in order to propagate the right workflow. And so I think there are some examples here where perhaps our job is not just to come out with great solutions, but also to perform some level of advocacy. I don't know, Chris, maybe if you'd speak to, like, how does the AMA look at this in terms of advocacy in order to really enable frictionless environments?
Right. I think I'll answer that from a personal, not an AMA perspective.
Okay.
But I think we need to introduce the notion of shared accountability, and that regulators have an accountability to have evidence-based regulation and to do the environmental impact statement about what does compliance with that regulation mean at the front lines. And so for AB 40 or whatever, what's the environmental impact statement of that, and how does that regulation need to be modified so that it can actually be efficiently carried out? And the other dimension of that shared accountability that I'd like to exemplify is we've talked earlier that a lot of the issues with the electronic health record aren't just in its design. Some are. Some relates to its regulation at the federal level, but a lot of it relates to decisions made at the local level. So what if CEOs decided to take on, as part of their responsibility, the doability of the work, and that there was shared accountability there? And I know that that's happened at Mayo, and it's happened at Atrius, and in other places as well. And what happens then is then the executive leadership team becomes responsible for the doability of the work. And at Atrius, then they have a Joy in Medicine initiative around their EHR use, and they have reduced their in-basket work by 30%. They've reduced 1 million clicks a day. They've had things like your SWAT team at University of Colorado to come in and optimize local units for their work. Well, how did that happen? It happened because the leader there was shared accountability at the institutional level. And I think we need it there, at the regulatory level, and at the vendor level.
Well, thanks. Maybe we can just, as we're closing out, I think one of the burning issues that we hear in terms of that friction in the experience is where we allocate time. Where do physicians spend their time? Where do clinicians spend their time? And is that really where we want to see healthcare time spent? It's a very precious resource. Maybe just to ask each of you to close out, kind of, how do you think about that? What's the thing we should be doing today?
Okay, so just I think some of the big takeaways from this morning, not just our session but the previous one, was also that it's equal parts the technology, but also the configuration, the time spent by the organization setting it up. Now, if you're already set up and you've been doing it for 10 years, it's probably hard to go back to the beginning and reconfigure it in such a way that's going to be perfect for you. But I think there's ways to go back and certainly retool it for that. From a where are we spending, the physician time, and that was an interesting chart showing that it was 11 minutes with the patient and 18 minutes without the patient, or 12 minutes, something like that, more. And I think the question needs to be, is that appropriate? I was kind of thinking that as well. I was like, oh my gosh, that's abysmal. You're spending way more time documenting it for billing purposes than you are for necessarily interacting with the patient. And it just occurred to me, like, is that okay? And I think the gut instinct is, no, that's not okay. We want to be spending more time with our patients. So to that extent, if we can reduce some of that documentation friction that's going on, some of that task-driven stuff, and build tools that help us sort of centralize that stuff to make it, and maybe organize it in such a way that the important stuff goes on the top. So, I think there's ways to do it in the short term without having to completely rebuild everything from scratch.
Josh?
So I know we're talking about near term. So certainly, one of the articles I published on LinkedIn talks about 10 years from now, so I won't get into that. But I think right now, certainly, something that we're developing and are going to be releasing in just a few months now is a voice assistant that's akin to what you have with Siri and things like that, where you can use your voice to interact with the EHR. Can you imagine that? So if you have your hands on the patient, you're doing an exam, you can ask, when was the patient's last colonoscopy? What was the patient's last hemoglobin A1C? Who does the next patient look like? All those sorts of things, so that you can multitask and you can focus on the patient without putting the software or the monitor between you. So that's something that's coming in the very near future from us in August. So we look forward to working with a lot of the folks in the room on that, and we are working with Nuance and Emoto on this development. We're just trying to figure out how you call it. What do you say to it to get it? We can't say, hey Siri. So we thought about, hey Jude. Mixed results on that feedback. So I'll get back to you on that later.
So Topher, as I think about where I, as a physician, have added value to my patients over my career, it comes in two domains. One is in relationship building, and the other is in medical decision making. So I think we need to measure, manage, and optimize for those two things. For the amount of direct, undivided attention that I can give to my patient, and for my ability to access, just as Dean Miner had suggested, a medical knowledge resource that can augment my own knowledge when it comes to hearing my eyeballs move, so that I can bring the power of shared knowledge into that personal encounter. I'm the transducer between all the knowledge that's out there and this individual patient. And so I think our technology needs to support those two missions.
At One Medical, we've put a strong focus on desktop medicine and reducing the number of tasks that providers need to take on outside of a full day of patient care. And one of the unique things about One Medical is that the goals around desktop medicine apply not just to the clinical team or the operational team or the leadership team, they're also goals of my team, the technology team building the EHR. And we've seen some really neat results of that. In the last couple of months, we've launched some machine learning, and we're able to immediately adjust the workflow to reflect the insights from the machine learning functionality we've launched. Essentially, we're able to better route messages to the most appropriate person to be able to handle those messages. And it sounds really simple, but we're able to pull about 15% of messages off providers and onto clerical staff that is totally capable of resolving the patient's need.
I think from a public policy standpoint, it's pretty clear that we're moving very rapidly into a value world and away from a fee-for-service world. And I think when one looks at natural language processing and an analytic unit and data feeds that go into an electronic health record, we're going to move from this game of maximizing income for a particular patient visit to how one maximizes income based on the health of the patient. And I think the EHR, with this support that we've talked about, is a really good tool to allow that to occur.
Well, thank you all very much. Please join me in thanking the panel for a terrific discussion. Terrific, and at this point, I think we have a break, so thank you all.
Yeah, okay. Okay, well, good morning. Good morning. We're going to continue with our next panel, which is on population health management, a health system perspective. And certainly no discussion of the electronic health record would be complete without addressing the opportunities associated with population health management. Now, by population health management, we mean bringing together the information about the care delivered to large groups of patients in order to better understand how to improve the value of the care delivered to individual patients. So it's about gleaning knowledge and understanding about care in a broad perspective over a large group of people in ways that can drive data-driven care delivery pathways that improve the care for individual patients. And we have a panel of outstanding health system leaders here today on this panel. And I'd like to introduce each of them. I'm going to sort of step back so that they'll have room to step forward and come in here. But first, and this is just in terms of the order of the people seated on the stage here today, Kevin Ban is the Chief Medical Officer at Athena Health. As a practicing physician, he brings more than 20 years of clinical experience, innovative medical system development, along with healthcare practice and performance improvement to Athena Health. And Mark Harrison is the president, and you can go ahead and come up, Kevin. Thank you. Thank you. Mark Harrison is the president and CEO of Intermountain Healthcare, a position he's held since October of 2016. Previously, he held leadership positions at the Cleveland Clinic as the Chief of International Business Development for Cleveland Clinic and as the CEO of Cleveland Clinic Abu Dhabi. Brian Hoberman is the leader of Health Connect, which is Kaiser Permanente's electronic medical record system. He's the leader of Health Connect for the Northern California region of KP, but also for the 8 Permanente medical groups. He's a practicing hospitalist physician whose role with Kaiser Permanente Health Connect began in 2002. Natalie Pagler is the Chief Medical Information Officer for Stanford Children's Health and Clinical Associate Professor of Pediatric Critical Care Medicine at Stanford. She recently helped lead Stanford Children's Health through a transition of its comprehensive electronic health record to Epic. She also serves as Associate Program Director of the Clinical Informatics Fellowship Program at Stanford. And Rishi Sika is the President of System Enterprises for Sutter Health. He joined Sutter in February of 2017 and has executive oversight of the system-wide services, including pharmacy, service centers, home care, laboratories, care coordination, and physician services. So I thought I'd begin with a question for each of the panelists, and maybe, Rishi, we'd start with you and then work our way down the row of panelists here. And that is really sort of a broad question, but each of you can choose to focus on the specific aspects that are most meaningful in your environment and in the system you're involved in leading. But that is, how can EHRs be used by health systems to improve value in healthcare, and that is to achieve better outcomes at lower cost? And maybe if you could start by, Rishi, if you could start by describing the landscape today, but also what you see moving forward, and if each of you could be thinking of that as we move to other panelists.
Yeah.
Rishi?
Thank you, Lloyd. And in terms of sort of describing my perspective, I think it's informed both by my current experience and my experience at Advocate Healthcare, which is fairly steeped for probably almost a decade with respect to population health and risk-based design, and Sutter Health, which is increasingly moving in that direction. And when I look at that landscape in terms of what the current state is, a framework that I like to use to think about this intersection of population health and EMRs is a 3-part framework around measurement, resource allocation, and managing the risk. And the issue around measurement is you fundamentally need to be able to know your performance. You need to know how you're performing with respect to quality, with respect to utilization and cost, at the individual level, at the practice level, by physician, and in a variety of ways. Measurement is the foundation. The next part, I think, is around resource allocation. you need to understand what are the risk factors in the population that would merit being able to provide certain resources, programs, and interventions. Who would benefit from what? And once you have that piece of resource allocation, then you need to be able to manage the risk. That is, you need to take that measurement, you need to take the resource allocation and the models that drive that, and then be able to integrate that at the point of care so that you know when a trigger occurs, then you can actively intervene on a patient, and being able to do that really within the workflow and in the care cycle itself. Now, I think that's sort of the operating framework about how to understand the current landscape, and that's actually really, I think, what's going to drive forward as well in the future.
Great, thank you. Natalie?
Yeah, thanks. So I definitely have been very pediatric focused, and so I'll take the question from a pediatric perspective. And I think that population health and pediatrics is really kind of an untamed frontier for a couple reasons. One, because of the relatively lower amount of healthcare dollars that go to pediatrics, and two, because of the relatively small populations of children with disease that we thankfully deal with. And so I think despite those, or partially because of those, there's also a tremendous amount of potential for pediatric population health truly improving the way that we deliver healthcare to children. Because we have much smaller numbers of children with much smaller number of patients with any one particular disease, it's incredibly important that we're able to look at populations beyond our own healthcare systems, congregate data from across the nation, across the world, and really truly define the best practices for children, because in many cases, we just haven't done that. So for example, in the treatment of bilirubin, hyperbilirubinemia, jaundice in infants, we have fairly good standards for how to treat your average full-term child, but when you look at the population of premature infants, a very small population, trying to define what the best practice there is challenging. And so the way that population health has the potential to really impact this is by thoughtfully designing our systems to both gather the data that we need, to analyze that data, and then to provide that information to help standardize those practices. So for example, John Palma, who is one of our medical directors of clinical informatics in the NICU here, has created a tool that both standardizes best practice by providing expert-based consensus, but then collects information for each and every case of premature jaundice and stores that, and then they analyze that and use that data to feed back into the clinical decision support tool. So you're really truly creating a learning health system. And like I said, in pediatrics, this is absolutely essential because we haven't defined best practice in many areas.
Okay, thank you. Brian?
Thank you. You know, population health is it's central to the way that Kaiser Permanente looks at care. We've been value-based care before it was called that. And it was all about prevention and health maintenance. And in this world that we're in now, where we have comprehensive EMR that's used in almost every setting of care, we have a wealth of data that allows us to, as one of my colleagues once put it, see through walls. And in doing that, we were able to recognize care gaps or care opportunities. And then the challenge becomes figuring out which ones of these, because there's so many, rise to the top in terms of priority. And then doing all the thinking and planning work that it takes to figure out how to exploit the opportunity and deliver the real value to the patient. Because it's one thing to be able to compute something, it's another thing altogether to be able to actually execute on it. And it's the execution that we put our main focus on. In fact, about 3/4 of the work that we do on any given technology project, including the population ones, is devoted towards the planning, which mostly includes workflow planning, and only about 1/4 of it goes towards the technology piece of it. But you know, because there's so many opportunities, and because the spectrum of care is so broad, from the littlest and newest patients actually to the pregnancies that lead to them, and then all the way through all aspects of life itself, And because the company is so rich with experts in these areas, we're constantly thinking through where can we find the biggest opportunity that will deliver the most value. And that question is then combined with, is there alignment operationally to be able to execute once we figure that out? And that alignment turns out to be challenging because of the scale of the organization. And so an incidental benefit of these kinds of conversations is that we bring people together to discuss these things. And as all of you know who've implemented these sorts of systems, that leads to kind of looking under rocks and all kinds of very useful things happen. And so just the mere task of shining light on something tends to reveal opportunities that are not only related to the population itself, but also to overall care delivery.
Mark?
Thanks. So my gut told me to go with the usual stuff and tell you how we use our EHR to standardize care through care process models and create high reliability care, and that's all true. But this is about population health, and population health is really about keeping people well, is the way I think about it. And I'm kind of obsessed these days with this idea of the 50-40-10 model, where half of your health is your genetics and 40% is your behavior and 10% is what we do in the clinics and hospitals. And recently we've used our EHR to understand the 100,000 full risk Medicaid patients that we take care of, and to analyze what we call ambulatory sensitive conditions. So things that should have been cared for in an outpatient setting that are getting done in the emergency department. And then we went back, and after we identified that, we tried to figure out why people were coming to the ED. And it really turns out that transportation was a huge problem for them. And we've instituted an Uber program for these folks and are seeing enormous changes in utilization of the emergency department. So I guess what my message is to you is that I think the EHR becomes a convener for really interesting ideas that are above and beyond the usual stuff that lots of us have done for a long time. And I'm an ICU doc, a pediatric ICU doc also. And it is weird to be an ICU physician who now all I think about is public health. Right. Yeah.
Great, thank you. Yeah, they really go from one extreme to the other.
Absolutely.
But I'm going to pick up on your thread, Mark, and say that when I think about successful population health management, and my first experience with that was at Beth Israel Deaconess Medical Center, where we had gotten involved in the Blue Cross Blue Shield AQC contracts, the alternative quality contracts. And so we had risk pushed down onto us. And so what I'll tell you about that experience, and I'll talk more about it, is that this is not really about the electronic health record. That can be a potentiator. What that first experience with risk did was it made us think about how we were delivering care. And we started to go through the practice of practice redesign, transformative care, however you want to refer to it, where all of a sudden it wasn't just about episodic churning and burning of patients, but it was trying to, number one, understand our population, which, by the way, we had no understanding of our population. So we needed technology to aggregate the data and normalize it. Next, it was to really understand, and people have touched on this, who were the folks that we needed to be touching that we weren't, and then how were we going to design care such that we could in a scalable way. So that meant using care managers and nurse practitioners and health coaches and pharmacists, and it became the practice redesign that really drove our outcomes. As we did that, we realized we need more technology to do this. And we need technology not only in the hands of the providers and the care team side, but we need to push that towards the patients. And these are all themes that we're talking about today. So when I think about population health management, and I heard Roy from Humana say in the last panel that we're moving quickly to risk, we're not moving quickly enough to risk. I would guess that 10% of our population is in a risk contract. And as you've all heard before, the concept of interoperability is not a technical problem. It is a political problem. And the moment we incent people to do the right thing is the moment we're going to see them collaborating. We see that in Boston between Beth Israel Deaconess Medical Center and partners. Previously, we never collaborated, not because there were nefarious reasons, but now that there's incentive to take care of populations that run between the two organizations, we figure out interoperability. So for me, we're not getting there fast enough with the thing that we really need, which is incent people to do the right thing, and then they will.
Great. So maybe continuing on that theme and delving a bit into the policy front, which we haven't talked about a great deal today, but could you, and maybe, Kevin, if you continued on the theme of, it's not the technology that's limiting the interoperability, I mean, by and large. I mean, there haven't been the incentives in place to achieve the interoperability. And you said, I think quite appropriately, that we're moving towards risk assumption on the part of providers and delivery systems, but the pace at which we're making that move is somewhat uncertain, particularly now. So what would be helpful in the policy dialogue, and maybe we can come back this way with that question, starting with you, Kevin, what would be helpful at furthering it? You mentioned, for example, in Boston, that the fact that there is more moving into a risk-assuming environment, and that therefore it became in the interest of both the BI Deaconess and the partner system to be able to freely exchange information, because each was going to lose if they weren't able to. But how does that generalize then to other environments? And by the way, how do you take it out of Boston into other markets?
So I joined athenahealth 2.5 years ago, and I'm really glad that I did that, because I trained at BIDMC. I was an academic doctor at BIDMC, and I had not seen the world. I can tell you that things that we would frequently discuss in conference rooms are being done in Western North Carolina by Mission Health Partners. They have recognized that this is not about diagnosis and treatment, the thing that I thought it might be about when I first got into pop health, but it's about understanding patients who suffer with behavioral health and who have major social determinants of health. Mark, you mentioned one of the big ones, which is transportation. So I think what we need to do is, I guess I'm not hopeful that we're going to see a lot of legislation that's going to push us closer to risk. But what is interesting and that's happening, commercial payers are getting there at different rates, but it's self-insured employers, really, who are on the hook and who are beginning to push risk onto their employees through high deductible insurance. So I think we're going there slowly in a very unorganized fashion. I think we earlier heard about consumerism. I think more and more as risk gets pushed onto providers, health systems, and onto people, you're going to see a need for the enlightened, consumer-driven patient, and they're going to need to have the solutions, technology solutions, that are technology-enabled services, really, that are going to get them there. So not a really clean answer. I guess I'd like to say, well, I'd love to see our government push us towards that and the commercial payers to follow. I'm not sure that's going to happen. I think it's more likely to be self-insured employers and their employees who are on the hook.
Great. Mark, what are your thoughts?
Great. Well, I'll take a little bit of the same tack. Anish, are you out there? So are you going to talk about the VA pledge during your session? So actually, I'll leave it at that, because I think that's actually a really nice sort of policy kind of piece. I'm actually of the same mind you are, Kevin, that I think this is sort of like solar power, and that economics are going to drive solar power, legislation is not going to drive solar power. I think there's an inexorable move towards value, and I do think that consumerism is going to spin that wheel. Actually, to that end, we brought a chief consumer officer on at Intermountain who actually he was the global head of consumer insights for Disney before he joined us. And he's actually helping us digitalize the system, and we brought the consumer's voice to the table in every conversation. And I think that's going to be what really drives things.
Great, thank you. Yes.
So I'm in such a different world, right, from this world.
You're in a good world.
Yeah.
Right.
So I guess let me talk about the perspective of the good world.
Yeah.
It's still healthcare. Patients are still patients. And we need to execute to be able to meet their needs. And executing means providing them with lots of different kinds of services, some of which we don't yet understand. But when all barriers are gone, there's still going to be some folks who have their own barriers that prevent them from coming in. We have incredible outreach. We are able to find folks who need to come in to manage their diabetes or their hypertension or whatever, and we're able to actually pick them up. We're able to, find them and all that, and that doesn't necessarily mean that they're going to choose to come in for whatever reason. So the consumerism mindset means kind of meet people where they live, and then it sort of gets beyond the scope of the EMR and potentially even beyond the scope of the health system to say, and then what, right? Because if they're not willing to accept the help that in many cases is free, then we've done everything we can to reach them. But in a world in which the barriers to reaching them are not as severe as they are in the kinds of challenges that other organizations have, what I can say is that the vast majority of our patients are open to that, and they love the easy availability of the services, and we love being able to provide them with the services. So the next step for us, and the thing that we focus a lot on, because the basic population health things we were good at even before we had EMRs, because we had digitized data long before we had EMRs. Now it's about finding the niche populations and understanding where there are care gaps in those niche populations that would meaningfully improve the quality of somebody's life, or other things that are just terribly important to the patients, and not to mention increase the joy in meeting in medicine, because we as a health system, we don't like to ever have the sense that a mistake occurred because we didn't follow up on something that we should have followed up on. And so we address a lot of our energy towards identifying where those gaps are and using the technology that we have along with the way we organize the organization to be able to close those gaps.
Great. Natalie?
Yeah, I think these contrasts are incredibly important to look at. I think the contrast that Kaiser provides, I just spent the weekend in Toronto at the Sick Kids Hospital supporting their EHR go live. I've helped with Melbourne Children's Hospital go live. And I think some of the issues that Lance Downing and Chris Longhurst highlighted in their paper, the regulatory context that we're in really does significantly affect how we're utilizing these tools, how we're providing healthcare. And I think, as Kaiser has shown, you can operate under a lot different context with the right structure or the right you can focus on the right things if you're working in the right context. And so, and again, we were kind of highlighting this in the last panel about how challenging it is, both from the provider perspective and from the patient and family perspective, when you're living in a world of mixed risk models versus value models. You're constantly spending energy trying to figure out what are my options for this patient, or as a patient, how do I figure out what this is going to cost me, or what I can do, what I can't do, and that's wasted energy. So I don't, living in this country, I don't know quite what the right answer is, but I think it's important that we continue to study these contrasting models and understand how many fewer barriers there are, so that we can really start advocating for overcoming some of those.
I agree with much of what has been said. I think that the economics will probably fundamentally drive interoperability, but I'm not sure it's going to be sufficient. And let me give an example to illustrate both of those aspects. Now, in my previous organization at Advocate, when we entered into our first commercial ACO contract about 10 years ago, that really drove the need to solve our internal interoperability problem. And we decided to partner with Cerner in a strategic partnership around population health, created a platform that integrated 43 different sources of both clinical EMR data from many non-Cerner EMRs, and then claims data, and then integrating that into workflow. So we had to solve the problem because now we owned and managed the risk. So I think that's an argument that the economics do drive it. But I'm not sure it's going to be sufficient, and that is, I think, because unfortunately, in spite of the fact that we are having this conversation about population health, I do think that there is a prospect over the next decade of seeing an increasing fragmentation of care in our delivery system. And this is a pretty profound macro trend that I think we're starting to see play itself out. So if you go back to the passage of the Affordable Care Act, there was a lot of conversation at that time that we were going to see this great convergence. That is that plans were going to become more delivery system-like, and delivery systems were going to become more plan-like. Well, guess what? It's happening right now. And if I could take the opposite perspective, not from the delivery system perspective, but from that of the health plan, in particular, for-profit health plans are fairly aggressively now acquiring delivery system capability. But the delivery system capability that they are not getting into is on the hospital side. So when you look at a health system, particularly hospital-centric health systems, right? And now you have plans that are actually acquiring the delivery system capability to provide a great portion of care, right? Within that system, within that technology platform, within that EMR, but at the time when you need that information and data the most, which I would argue is at the hospitalization in the ICU, it's in a different system, right? So if this macro trend continues to play itself out, which was something that was talked about many years ago, I think is very active without talking about all the deals that have been happening in the past 18 to 24 months, that fragmentation of care, particularly from the intensity of the inpatient side and then all else, particularly as this dynamic plays out of payers acquiring delivery system capabilities, I'm not sure the economics are going to be sufficient to be able to resolve that.
Great. Natalie, in the children's world, blessedly most children are healthy, but those children that are sick frequently have chronic and multiple conditions that require an enormous amount of longitudinal care inside and outside the delivery system. How complete today is the aggregation from all the different social service organizations, home care organizations that interact with the sickest children who receive their care through our children's hospital, and you and your colleagues, the providers? Are you getting the type of information you need, and how can a future evolution of the electronic health record or related systems help you to provide that type of integrated and coordinated care that you need to optimize the lives of these children and their families?
Yeah, it's a great question, and there's obviously lots of opportunity for continued optimization. And I think, as we've touched upon already in this panel, so much, especially in pediatric care, so much of health is not determined by the small amount of time that we spend with them, but by the larger socioeconomic factors that they're living in. And so I think there are examples where we have been very effective in getting the right resources together to truly improve children's lives. So, for example, some of the large pediatric collaboratives like Improve Care Now, which is focused on inflammatory bowel disease. KT Park at our organization is helping to lead that work here, but it is a national effort, and they have both collaborated with hospitals across the nation and developed really interdisciplinary care teams, everything from the dietitian to the social worker to the case manager, and really looking at how do you holistically change these children's lives. And again, they've used the EHR in this case as a tool to create structured documentation that both helps collect data that will, again, feedback, create this learning health system, but then also guides practice within the documentation itself. So I think there are wins like that. Another example is in our work around diabetes, type 1 diabetes. Again, very multidisciplinary disease process. You need your physicians, but you also need your dietitians and your educators. It's really about changing their entire lifestyle and supporting them where they're spending most of their life, which is hopefully at home or at school. And I think the EHR plays a role, and Priya Prahalad, who's one of our endocrinologists here, has helped create a registry for type 1 diabetics and is able to really identify some patterns for outcomes in our own population. So, for example, we see a lot of our patients who are in the Silicon Valley with utilizing higher levels of technology and having some better outcomes, and then we see some of our patients that are in some of our farther outreach areas with more challenges. And so I think what's exciting here is the role of digital health to really enable that kind of, again, multidisciplinary, complex look at how do we actually impact healthcare. So for example, taking the data that she got from the EHR, realizing that some of our patients in our outreach areas are not getting the same level of support or care that they need. She's helped create some innovative care models where they are doing video visits in the schools with the school nurse, with the mom, with the interpreter, with the dietitian in the room, and that's really enabling everybody to work together at once to provide that type of integrated care. So we have a long way to go in creating more, integrated and seamless systems, but I think some of the tools that we are starting to use, especially when we're using them with really creative physicians who understand the needs, we're starting to create better, fully rounded healthcare.
Thank you. Natalie, as you were describing your work with individuals with diabetes, it reminds me, I think one of the fundamentals of our work in population health, and we had talked about this a little bit before, I think one of the fundamentals is we want to move averages, right? We want to have the average hemoglobin A1C improve. We want the average systolic blood pressure to improve. We want the average cost to improve. Unfortunately, a lot of our conversation in population health tends to focus on tails and just working on the worst. The individuals who have the worst level of control, or the small group of patients, 10 to 15 to 20% that account for a disproportionate share of costs. But if you accept the premise that our goal in population health is to move averages, you cannot focus on tails and move averages. That's just the math. Right? That's just how math works when you're looking at moving averages in a normal distribution. Now focusing on tails is important from a financial perspective because they can bankrupt you. But really, if you're going to move averages, you can't just focus on tails. So I question a little bit sometimes our focus on just the tails and individuals or populations that account for disproportionate cost or disproportionate utilization. You actually need to do something for everyone. And that is, I think, an important thing to realize as we work this sort of model of the technology, the data, the analytics, and the EMR, and the types of interventions. And I think what you were describing was very holistic and targeting a very broad swath.
Great. Mark, a lot of the patients that receive care in your delivery system live in very, very rural areas. And you've been an innovator in looking at novel ways to provide that care, including advances in telehealth. Can you give us some of the highlights of those programs, what's working and where are the challenges?
So we may be the only system that's represented in the room that has a hospital with a hitching post out front. So. And we actually do. So our day-to-day footprint's about the size of Italy, or about the size of the UK, but we have only 3 million people who live in that area. And some of the hospitals and clinics are literally 100 miles from the next town. And so out of necessity, we started to actually provide a lot of distance health to folks. That has actually now turned into a strategy. We currently have more than 100 teleproducts that are in day-to-day use at Intermountain, and now in 5 Western states. So we're actually expanding fairly aggressively to help other people. It's not a great revenue model at this point in time. We are not trying to extract patients from other hospitals and just fly them to our places. In fact, what we try and do is keep people in the least restrictive environment, as close to home and as close to their families as possible. And it ends up being economically okay, but we really think that in the future, this is going to bear a lot of fruit, both for the communities as well as for the hospitals that we're serving. Because as many as a third of rural hospitals could just go away in the next 10 years. They're not economically viable. And what we're finding is when we support folks, they do become economically viable. So just a couple of really quick examples of the kind of care that we provide and make these hospitals stay viable. First, antibiotic stewardship, huge problem across American healthcare. We have one team that covers the entire system. Everyone gets the same antibiotic stewardship, regardless of whether you're in a 20-bed rural access hospital or whether you're at one of our major centers. Secondly, telestroke. There's one Joint Commission certified stroke center in our state. It's at our place. It's at our flagship hospital. That said, we run a telestroke service that covers the entire system. You get the exact same care with the exception of intra-arterial therapy, which they can't provide at all the little hospitals, everywhere in the system. Amazing results. And then all kinds of things like tele-newborn resuscitation. So imagine you're in a little hospital that has passes at each end of the valley that get closed in the wintertime, and a mom comes in who's in preterm labor. And the team has not resuscitated a newborn who's going to be this sick for months and months. Well, it's really easy. We put one of our neonatologists on. While the mom's laboring, they do real-time training with the resuscitation team. Baby's born, resuscitation occurs, the neonatologist stays on the line. If the baby needs to be flown out, the family's actually already met the neonatologist, and their transition is seamless. This happens every day. It's part of our operating model. And now with the launching of our virtual hospital, it'll become a part of our commercial model as well.
That's great. Cool. I'm going to ask, just to give people a heads up, one final go-around question in just a moment, and that will be if you could think about the one thing you'd like to see more focus on, say in the next 3 years, that would help drive this transition to better management of population health, what would it be? So I'll plant that question for people to think about. But before getting to that, Brian, you've been with Health Connect now for about 16 years. You've really been instrumental in evolving the electronic health record system for Kaiser Permanente nationally. Can you describe the process of changing the system, or how it evolves, both with input from the people who are receiving care through KP and also through the providers that are using the system every day? What does that process look like?
That is a process of getting the information to the folks who understand. So it begins with, this kind of gets back to some of that conversation this morning of people who are alienated from the tools that they use or don't want to understand the tools they use. The pilot absolutely understands what goes on with the technology on their plane, but the physician is like, why would I want to learn about that? I'm here to see the patient. But not every physician is like that. Not every nurse or social worker or pharmacist is like that. So finding those folks who are interested in the technology, who sit side by side with others who maybe aren't as interested, and using them as kind of eyes and ears to help understand what's taking place, what people are struggling with. Also having panels of patients who are able to discuss what it's like using the portal or other pieces of technology and being able to get that feedback, and then funneling that feedback in ways that kind of preserves and curates the meaning of it so that folks who think long-term and short-term about the tools in the system are able to kind of figure out, do we already have a solution for this? And this is a case of the future's here, it's just unevenly distributed. We need to get it over to folks who don't understand this, or is this a true gap? Is this a mistake? How quickly do we need to fix that? And is it internal or is it external? And because external is complicated, of course, Epic is our vendor, but there are many, many other systems involved. As you were saying from IBM earlier, there are many other systems involved. It takes kind of a lot of figuring out sometimes to say, okay, here's where the problem is, or here's where the investment needs to be to get there. So what we did was we built infrastructure that allows us to capture, understand, curate, and communicate that information, leading up to oversight and governance processes where we can kind of make those decisions.
Great, thank you. So Kevin, if we could start an easy final question with you. What one thing in the next 3 years to improve population health management value in healthcare?
I'm going to come back to the concept that I kind of started with, and to Taylor Davis, if he's still here. I thought it was really, there you are. I thought it was really interesting what you told us about organizations that really go through the process of good change management that drive outcomes, right? And I think that's the point I'm trying to make too. What I'd love to see is a model wherein care teams have the latitude to make decisions and have the resources to do their work, and they do that in a very aligned way. Technology serves to potentiate that. But technology won't solve that. That's why people on the same technology, but who manage it differently, are more successful. And the other side of that equation is the patient-centered piece. Now, we've said it way too much. We're all a little, sick of it. But I believe that the moment we truly drive towards patient-centered care and we put power into the hands of the patient as a part of that care team is the moment that Copernicus had when they decided to put the sun at the center of the solar system. And everything starts to get a little bit easier instead of creating really complicated algorithms to make something that doesn't work. So that would be my hope, that we could see practice redesign, that we could see those teams be given latitude and resources, and that we could see technology support that effort.
Thank you. Mark?
For me, it's personalized health leading to population health. So I'd like to see increasingly tools built into the system that allow people to get very much tailored information. So our depression algorithm now includes genomic testing for every patient so that people get on the right drug as quickly as possible. It ends up paying economically also if you have a population health model. It's good stuff. The second piece is let's just ask patients what they want in like real language and not talk about their heart failure classification score. Let's ask them, do you want to dance at your daughter's wedding? Right? And then we'll get real information about how we keep them well.
Great. Brian?
I really liked these examples that took the concept of population health all the way down to a telestroke event taking place, or that kid getting help in a remote area for managing the difficult disease the kid has. Ultimately, it gets down to the level of the patient. And, we have just at any given time a finite amount of resources, and figuring out how we can correctly allocate the resources to solve problems where it would make a material difference is the challenge. And, in our organization, I think we're pretty good at it for, the plain vanilla and maybe a little bit of other flavors too. But as technology evolves, more and more of these opportunities open up. And a lot of the fun and the challenge is figuring out how to match the organizational knowledge and capabilities with what these opportunities are. So looking ahead, the work is actually mostly people work and organizational work, and trying to understand how we can accomplish that as the technology keeps evolving.
Thank you. Natalie?
I completely agree. I think there's so much people and process work here to be done to really make sure that we are using the technology in a meaningful way, incorporating it into our workflows and focusing on the outcomes for the individual patients. And I think, outside of Kaiser, unfortunately, some of what needs to continue to be done is getting clinicians involved in advocating for the context that will allow us to do the right thing for the right patients.
Thank you. Rishi?
I do think that over the next several years, I sort of put forth this framework around measurement, resource allocation, and managing the risk. And I think from a very tactical perspective, that is what's going to be needed to move forward. I do think, though, in the next 3 years, we're going to have, as an industry and quite frankly as a country, a fairly difficult conversation around this topic of social determinants of health and its intersection with population health. And if please forgive me for a moment, but I think part of that is that we're going to have to stop using this term, social determinants of health. I think it's a euphemism that allows us to not say and talk about some very, very difficult things like poverty, income inequality, food access, housing access, racism. And I think until we are willing to actually, and I could see folks just now bristling a little bit about the way I kind of called it and said it, but you can't have the conversation about population health and managing risk without us also having that level of blunt conversation over the next couple years about what we're going to have to do as an industry and quite frankly, I think as a nation too.
Great. Thank you very much. Thank you to all the panelists.
We are like-minded. Of course, but yeah.
It's now a pleasure to welcome the moderator for our last panel, Cliff Leaf, the editor-in-chief of Fortune magazine.
Oops.
That's great. All right, let's come on up, everybody. Right. Yeah. Let's get the whole crew up, and rather than do the beauty pageant thing where I introduce you and then you come up. Exactly. It's so let me start with introductions real quick. I'm not going to go through everybody's bio here. Anish Chopra, right at the end. You probably all know him here. He's the president of CareJourney, an open data intelligence service launched by his own incubator, right? By your own, what you call your hatchery. And he's, of course, the former chief technology officer for the US. And we have Julia. Julia is a director of the Clinical Informatics and Improvement Research Center at UCSF, and she is an expert on policy management issues related to the use of IT in healthcare, particularly on the adoption of healthcare cost and quality. And we have Jess Kahn, who is a senior expert at the McKinsey & Company and specializing in Medicare and social services programs, and recently named one of the foremost influential women in healthcare IT by HIMSS for 2018, and used to lead a data systems at Medicare at Medicaid for CMS. We seem to be missing some people here. I know we're getting mic'd up here. That is Lucia Savage. Wave to the crowd. She's the Chief Privacy and Regulatory Officer for Humana Health, and she is a recognized thought leader on using HIPAA to advance digital health while protecting privacy. And we have Dennis Lund, who is, of course, many of you know, he is the interim president and CEO of the Lucille Packard Children's Hospital, and a well-known surgeon specializing in, well, formerly trauma transplant, and now it's pretty much everything, right? All right. So I have to say that we had a pre-call. Sure. We had a pre-call, and it was feisty, and people were interrupting, and they were cutting each other off, and Anish in particular was like, "Hey, can I just say one nice point about this?" And then he'd like come and jump on everything. So what I'm hoping is we do not lose that. I am fantasizing that you will all interrupt each other, that you'll cut each other off, because it's late in the afternoon, or early in the afternoon, but late in the morning, and we have to get everybody jumping up here. The other part of this is that we've had a lot of this conversation for the whole day, and we know what the big issues are. And so what I'd love you all to do is interrupt each other or actually respond to some of the things that have been said here today. Lucia, I want to start with you because you were the latest to come up here on stage.
I knew you had a plan.
Yeah, exactly. No, but you mentioned something on the pre-call that I think was really interesting and I'd never actually thought of because I didn't think people could be passionate about EHRs. But you said, why don't you ask us why we're passionate about EHRs? And I thought, oh, that's a great idea. So why are you passionate?
About 12 years ago, right after Kaiser had kicked off its pre-high-tech EHR, my mother is a Kaiser patient. She was bipolar her whole life and also had COPD. And when she took steroids, they caused a manic episode. So very complicated pharmacology. She was taking lithium, and her PCP said, wow, your kidney function is bad. I'm going to switch you to an on-patent medication. This is during the donut hole. And I'm trying to explain to my family how to calculate when the donut hole, when you trip into it. And it was not a good drug for her. Sleepless, nausea, leg cramps, just everything about it was bad. And I said, you know, what did your psychiatrist? Well, a psychiatrist agrees with PCP. I'm like, have you seen a nephrologist? She said, what's that? I said, that's a kidney doctor. Let's get a referral to a kidney doctor. And we went to the kidney doctor, and he opened up the EHR, and there's like a 10-year history of her kidney results. He could pinpoint within seconds which ones were in hospital for other things and which ones weren't. And he said, yes, your kidneys are failing, but you're 80 years old. So who knows why they're failing? And by the way, they're not nearly as bad as you think they are because of all these other things I can see in your lab results. So put her back on the lithium, which she then, you know, took until she weaned herself off. So probably
another friend of ours, same setup, did not get to the nephrologist, took the drugs that weren't very good for him, ended up suicidal, and let's just say he's alive, but it was not a very good result. And so when I look at that, I think, wow, the power of this tool to be able to get the right information to the right professional at the right time really changed this particular patient's life. And so that kind of drives my passion for it.
Anybody else have a passion story here on this list? Somebody, I know, Anish, you actually mentioned something that I thought was really striking in the call too. You talked about our big problem is a grammar problem. You said, you actually repeated this many times. You said, we keep confusing our nouns and our verbs. Tell us what you mean by that.
So I think the conversation we've had all morning has been EHR as a thing. And if you recall, when we funded the $40+ billion, or I guess 34, Don, you'll correct me on the math, but what we did was we made a conscious decision to describe them as a series of connected modules. In a sense, the notion of the verb, that there's information that's flowing from A to B. And so every conversation you had earlier where the EHR as a noun was described as a thing that needs to get better, but kind of missed the actual underpinning of this story, which is it's not a single thing, it's a collection of things that are connected. And as long as we have standards-based mechanisms for connecting, we can unleash a massive creativity economy around ways to make it better for doctors, to reduce burnout, better for Lucia's mom to have more coordinated care, and as Rishi was describing on the earlier panel, these care teams that are evolving in these business models who can actually assemble the information appropriate at the time. Today, we feel like we have to sort of pray at the altar of the EHR vendor to make a release to their product to make it slightly better. And I think that that's a little bit like, what are you talking about? We have standards-based methods to exchange information. We should have the ease of simplifying our lives with downloading a third-party app that can plug right into the infrastructure and work, because the verbs, the mechanisms of moving information through the system, are standardized. So it's not the technology issue, it's the data standards opportunity that was enabling this new, hopefully a marketplace of components that we call collectively the EHR.
So I heard a few adjectives in there as well. So it was nouns, verbs, and adjectives.
Yes.
Julia, a lot of what we've heard about and what Anish just mentioned is fundamental to what you've just written about, which is, we sort of rage against the problems raised by the EHR, and some of them are real, but a lot of what the EHR has revealed other kinds of problems with our systems management in healthcare.
Yes, absolutely. And I mean, I think I do get frustrated when so much attention and frustration is focused on the EHR, and then you say, well, is the root of the problem a technology one? And the answer is no. Well, then why are we trying to solve it as a technology problem? And I think if you look upstream, it is. I mean, when we've been talking about it in this room today, it's people, processes, incentives. And so to sort of continue to focus on the EHR as the problem, and then by default, the solution, we're missing the opportunity to really fix the key problems. And I think that is where we need to shift our conversation so that we can have long-lasting solutions.
Well, this is definitely going to be the first national symposium on EHR problems that isn't going to blame the EHR. That's my takeaway from today. But Jess, I mean, you also, part of your passion is let the computers do their job, right? So you want to liberate computer systems.
Well, I want to liberate the data that's within them. My main premise of this is whether it's clinical data or it's social determinants data or administrative data, a lot of the blocking has to do with people's lack of confidence in that data themselves. And this was part of the early resistance with adoption and sharing anyway, as people were afraid that the data would be incorrect. And what I would posit, and what we've seen it play out actually, is that the more eyes that are on data, the better it gets. And so when data resides in those silos together and isn't shared, then those problems just confound on top of each other. And so when you have broader data sharing between, say, care providers, between outpatient and inpatient, between community services, that's when those things get picked up. And that's where things get better. And so this continued siloing of data, whether it's in an EHR or in some state data warehouse, continues to perpetuate the issue.
So Dennis, how good is the data?
Well, I think there's a lot of very good data. The problem is how are we using that data to implement patient care? I mean, after all, the EHR ought to be about providing patient care, right? And it actually ought to be about providing patient care in real time, not just some data warehouse that's out there. So going back to Lucia's example, if I'm a doctor and I'm writing a prescription for her mother, and that prescription conflicts with some of her other prescriptions and is likely to cause her to have renal failure, why doesn't the EHR automatically notify me that in real time? And we actually are now implementing those kinds of things in some of the pediatric work that we're doing, where if you're on nephrotoxic drugs, 2 nephrotoxic drugs, easy for me to say, and you add a third, the computer system lets you know. What it ought to do is actually send me a page and say, did you really want to add that third nephrotoxic drug? And so that, that data is out there. We still have the problem of what I call the 17-year rule, and that is it takes 17 years to get into practice what has been found to be medical truth. But in a time where medical knowledge is doubling faster and faster and faster, we actually need to use the EHR as a partner. And this is where the whole AI piece plays into it.
So the connection between doctors and cicadas, that's what I'm seeing here right now. Anish, you have talked about this. We're not playing the blame game here, of course. So let's blame CIOs.
Sure. I'm in.
Okay, great.
Let's go.
So are there any CIOs in the room before we start? Okay.
Yeah.
All right, not that many.
More than lawyers.
Three or four. Okay, but this is and you give the example of fire, and you say, very few CIOs actually said, hey, let me take control of the third-party apps that are coming into my hospital system, and see if I can make sense of it.
Well, here was the context that kind of teed off this part of the discussion. So if you go back in history, 2015, there was a vigorous policy debate about how we were going to allow consumers to assemble their health information by connecting an application of their choice to that EHR system. And Dennis, in this analogy, the patient who comes to you who has a community pediatrician who's on a different EHR might have a medications list in that system that may not be known to you for all the reasons of interop and so forth. So might the patient have an app that could allow that system to communicate? So we spent a lot of time kind of figuring out what was the data set. It's not the entire health record, it's a subset of the record. And then how might you connect it? You'll hear this expression, the FHIR API, because all the major EHR vendors voluntarily, I might add, agreed to use a common approach rather than a vendor-specific approach to meet the meaningful use rule. Don has all the statistics. Over half of the certified products today all voluntarily agreed to use this open standard. And by the way, Apple, and the punchline to your question, and today's the Worldwide Developer Congress. We're all on the Twitter to see what Apple's announcing on Apple Health today. Something awesome is coming, I would imagine. We'll find out. The point is, Apple chose not to add an Apple widget as a proprietary method to assembling the record. They said, we're going to build on this FHIR API, this industry-led consensus effort. Oh, my goodness. Someone here earlier in the day was from Epic on the thing. Epic is awesome. Cerner's awesome. Everyone's awesome. I like everybody. Just to give you an example, Epic is the one EHR vendor that publishes this. They made the upgrade to turn on this FHIR API free to their customer base and available in December of 2016. I started asking questions of CIOs. Will you turn it on? Have you turned it on? It's like literally 5 clicks. It's like email Epic and say on. It's not like it was a multi-million-dollar project, complicated issues. And then I'll be like, oh, busy, other priorities, we'll get around to it, blah, blah, blah. And so the adoption rate, because Epic publishes every site that was live, very low. And the irony was I'd see a CIO who's like speaking on the future of AI, machine learning, and then their name's not on the list, they haven't turned it on yet, okay? So by the way, Apple announces they're embracing the FHIR API. And they announced the systems that went live in that, whatever the first dozen or whatever it was. And all of a sudden, I start calling a bunch of CIO friends of mine, like, Anish, the board is yelling at us. We are not on the list. We have to be on the Apple list. So all of a sudden.
This is what the call was like, by the way.
Yeah. What's amazing.
Yeah, that's true. That's right.
What's amazing in this story was we've come from a compliance mindset.
Right.
Not a let's make this better for Lucia's mom mindset. Right. Nothing. No technical budget burden got in the way.
But I have to jump in there because I was there when we wrote the rule. So first of all, what you all have to know is very deliberate. We very deliberately wrote the CMS rule and the ONC rule to sit on the bed of the patient's right to get their data.
Yes.
You all have that right. Your patients all have that right, and it's been around since 2000. It is not new. All we did was applied some digital facts. If you go back to your institutions and your lawyers are like, what is she talking about? I'm happy to get emails and tell them where to go look. But the second thing I would say is I was just a month ago talking to a room about this big full of people who manage the records rooms in your institutions. And I said, show of hands, how many of you are talking to your CIOs about what the FHIR API is? The only hand that went up in the room was the developer who works for the company that services the information rooms. It was really sad. And how many of the institutions are hugely capitalizing? The board is screaming about the Apple list, but they're not capitalizing, empowering computers to do what they do best, which is move things out of sets where they're not related, in the document rooms. Because for the profoundly ill people, it's more than just what's available in that Apple Health Kit. You need a lot more data to move to a lot more places. So yes, I'm glad the CIOs are hearing from their board, but I would like that noise to be a lot louder.
Yes.
So Kevin Ben, just a moment ago, he said something really interesting. I thought all of the panelists were fantastic. And he talked about the fact that, nothing really changed until Copernicus, until they decided that in the Copernican era that the sun was the center of the universe. Well, they didn't decide that. I mean, the sun is the center of the universe, to the best of my knowledge. And, but the question is really getting back to the patient. So is the patient the center of the healthcare universe? Let's ask that, because this patient doesn't feel like she's the center of the healthcare universe.
See, I took something else out of that panel. I heard that things didn't move until people started assuming more risk.
Yeah.
That's what I heard. Did anybody else have that impression? When the incentives aligned, that they had to understand what was going on with those patients because now they own some of the risk. Then they started asking questions about whether people have transportation. This drives me crazy, this question, because we've been answering this for 15 years. Speaking of AI, you don't need it. Just posit that if you are a low-income Medicaid beneficiary, transportation is an issue. And then ask them to prove the affirmative. Oh, and you can also posit that they do have access to a smartphone. Let's stop arguing about that as well. So I don't think that patients are still at the center of it. And I would actually say maybe pediatrics is the exception to that, but it always has been, digital or otherwise. So I would say it's still a policy and financing that is at the center of that. And I'm not talking about what makes people happy and what gets them into their careers and their jobs and the passion they bring. That's obviously patient-centered care. I'm talking about what makes the decisions for these huge shifts to change and for people to make these investments, largely because they have boards to scream at them. It comes when they are forced.
But it's funny. I think, go ahead, yeah.
Can I add something? So when I came in and I was reading my Harris poll, what I realized is that there's a corollary amount of data about what the patients and the caregivers really want. And the data has shown for about 10 years pretty consistently that between 80 and 90% of the patients already think that the physicians are moving the data for them, and they're upset, surprised, and frustrated when they have to make it happen themselves. 1. 2, that less than 10% of the population is really obsessively worried about their privacy in the healthcare system. Because of point 1, they expect the physicians to share with each other appropriately for that care. And so I think that when we think about whether the patient is at the center, there are a few assumptions within our institutions that we can challenge that might help us not just, we can rail on the regulators. I used to get wailed on. I'm a former regulator. But look at our own policies and procedures, and are we making it so much harder than it really needs to be so that we can free the physicians to do what we've spent all that money and all that time training them to do?
Yeah, I mean, it's interesting. I mean, I think of myself as a pretty educated consumer. I book my own travel. I, buy things on Amazon. Woohoo! But the one thing I don't do is I really don't control my health records. I actually, and I write about healthcare on a pretty consistent basis, and I don't control that. So I'm actually not in the driver's seat. And should I blame myself for this?
No, I mean, I think the point is you have the power to do it if you want.
Yeah.
But the rules, the federal rules in the system are designed so that you don't have to. Cliff, if you got sick, we would want you to focus on following your doctor's instructions and getting better. We wouldn't want you to have to worry about the middle envelope or the red robe that's this thick, full of stuff. And if you don't know Bray Patrick Lake, you can ask her for a picture of her medical record, and it's like 5 notebooks and 3 CDs. How many have a CD reader? Anyone have a CD reader at home? Yeah. So we want you to get better. We don't want you to be the librarian. You can be. And maybe you'll help us crack loose the interoperability rock, because you'll be using the apps that we set up, but we don't want you to have to do it. At least that's what I think.
What also spurs it is, especially with the population shift growing, where more people are living longer, it's the caregivers who are now paying attention to that. I don't mess around much with my own data, but I know all about where my mother's data is, and I know all about where my youngest child's data is, because both of them have interacted with the health system. So if this isn't a person issue for the individual now, you better believe it's going to be for your parents or your children or whoever, your spouse, whoever it is that you're caring for. So we have to think about ourselves in that context as well.
Cliff, if I may just take 2 quick things. Actually, Dennis, you should probably go first. I'll pick up on that back.
Well, 2 things. One is we are beginning to exchange records much more easily. We've now, since our Epic go live at Packard Children's Hospital, we've exchanged over 14 million records in all 50 states. One could argue.
With other Epic systems?
With other Epic systems. With other
What about
Epics.
with non-Epic?
Well, and that's a good question.
That's kind of the question.
It's a good question.
That answer? That's a big question.
But my second point is that there's another part of this, and that is about patients being able to own their own health records. And so I'm going to ask Natalie, sitting here in front row, what's been the biggest roadblock to implementing open notes? Providers. It's providers.
Yeah.
And I'm one myself.
We are totally blaming people. I'm just saying, right for the record, there's a lot of blame coming here.
But there still is this fundamental disconnect in the physician, in the provider community about whose record it is anyway.
Right. Dennis, this is a good segue to the question. I was going to make a comment and then a recommendation. Comment. In the first version of Meaningful Use, stage 1, a requirement we added was that the consumer had the right to an electronic copy of their discharge notes within 3 days. The rule was 50% of the patients who requested get it, 72 hours, exactly right. So Dennis, there's no provider judgment in there, you get it. And Don will tell you the statistics, 93% of all hospitals comply with the order. Okay, so that's a happy story, with one massively embarrassing footnote. In the definition, we made the denominator in this metric the number of patients who requested it. And Don will tell you, including some of the major fancy names that are in this room today, 54% of all hospitals in the United States of America, obviously not Dennis because he's not Medicare, 54% of all patients, of all hospitals said, under penalty of perjury, I might add, that not a single patient requested it. This is 2000, forget APIs and Apple and whatnot. This is like email a PDF version of this to my Gmail account. That technology, okay? Since 2010, the rule, 11, 12 when they first rolled out. So majority, that's discharge planning offices, Dennis. That's not the physician blocking it. It's the discharge office not telling you you have this right. Point 1. Point 2, there was a previous panel discussion where it's not a technology issue, it's the incentives issue. I will concede all that's true, but we have a data standards problem. Let me clarify. When Lucia and I had this back and forth about the medical records office, when the government regulated the EHRs, we only took structured data. Do you smoke? What's your problem list? What's your meds list? And that limited amount of information is what we regulated, and that's what's feeding all these open APIs. All the other information, pathology reports, clinical notes, everything else, which is the bulk of the record, unregulated. So today, there's no common standard for the data that's in the rest of the record and moving around. So Mark Harrison made a beautiful comment about what I assume is the PHQ-9 survey, the behavioral health assessment that flagged an intervention that he just mentioned in your one idea for whatever. That's not an open data standard. So if the primary care doctor in Utah does the exact same thing as part of their annual wellness visit, and they store the exact same survey, that's not feeding the Intermountain algorithm to decide whether or not the person gets the intervention. Not happening. Forget interoperability. It's just there's no mechanism that's not a standard. So Mark also said in the previous session, he signed a pledge to join with other health systems to help the VA, because at the time, Secretary Shulkin put a stop on his EHR procurement and said, I want the whole record, not just this minimal limited data set. And I want not only the patient to get access, I want the doctors to have access, and I want the care teams who support them. So I want multiple access methods, and I want the entire record. So this group of providers, including Intermountain, God bless America, and I hope many, many of you, will join voluntarily to say, let's just get a group of people to agree, what does the PHQ-9 survey look like when we share it? So we have common standards for the entirety of the record. Don will love you for it, because he's awesome. And I think we can make a lot of progress. So that's the gap between tech and data, that you can't just say, well, the tech will solve it. No, we got to do work. Once we get that work done, then we can apply the rules that Lucia said that says we all have the right to it to the consumer, and then we can make them.
But can I just bring two threads together? Because I think we've been talking about incentives and then standards, and I mean, they directly relate to each other, right? Because the harder it is to do it, the greater the incentives need to be to do it. And I think a lot of health systems are getting caught in between, where they say, we want to do this, but it's so complex and expensive that it's competing against everything else that our dollars need to go to. And so I think what we need to think about is, how can we make it easier to do it such that we don't need to ramp up the incentives to the same degree, because they directly trade off.
But here's the thing. So first of all, one could have a whole day on whether $40 billion was enough incentive or not, because that's definitely what you hear in DC, is that we spent $40 billion and this is all we had to show for it.
It was part of the Recovery Act, just to remind everybody that the purpose was not just to support the adoption of electronic health records, but also to support the economy.
And it was a
sure we're benchmarking it based on its intent, its congressional intent.
I work for a startup, but I would say definitely huge economic stimulus. But I want to go back to Anisha's point about the 54 hospitals, 54% of hospitals, because this weekend I was at the American Society for Clinical Oncology talking about something similar, and I got a tweet about faxing being required. And I said, no, there is no law that requires that you fax. And the message from a different tweeter that came back to me was, I'm helping my mother with 9 physicians, and 8 out of 9 of them require me to fax their office. And my response was, I bet they are all meaningful users, and I bet they all have a portal, and I bet they all took incentive dollars. And why is that portal not working at HHS OIG, which is the fraud investigator? So we have an incentive problem, as Julia said. We have some technology we need to work on making better and more expansive, and we have, within the system, we have the human factors of people are used to their faxes, they're unfamiliar with the safety and security of APIs. We can have a whole conversation about that. There's all these pieces. It's a very complicated puzzle.
We're here in the heart of Silicon Valley, and I asked you, Anish, I said, we were talking about Apple getting 30 health systems to be able to provide a very easy to use access health record for anybody on their smartphone. And you said Apple did nothing. They did absolutely nothing. You said, all they did was they said, you guys have to have the same standard and, the technical requirements. And the reason why they were able to do it was, whereas Nobodyville app, I think was the word you used, couldn't do that, was because Apple's Apple. And the question is there anybody else like Apple out there? I thought the federal government was the Apple of
That's who made it possible.
In terms of the big girl. I mean, who's pushing
If you follow all of the former Fed wonky tweets,
yes,
you will note that we made that point, that there was quite a fabric laid upon which that announcement came.
Yeah, but to answer the question exactly where Jess is going, the reason I said they did nothing, I did not mean that they did nothing. They obviously built services at the back end, but there's no specific Apple software anybody had to deploy unique to Apple.
There's no BAA, there's no backdoor, no.
Yeah, and that's the other thing. Could you imagine making your patients sign a business associate agreement to get their data?
It's not
How
necessary.
Ridiculous. Thank you, Lucia's right. So here's the point. What Apple's doing is a phenomenal public service.
Right.
They are laying the foundation, because once the systems turn on the Apple service, the marginal time and effort and cost to add it for a Nobodyville app is zero, virtually zero. And so the point I'm getting at is an advocate for the patient who can help bring the systems in line is critical, necessary, but not sufficient. CMS administrator, Seema Verma, did something wonderful. She said in March at the Health IT Summit, HIMSS, I'm not moving the deadline. Doctors and hospitals must be on a meaningful use, which is essentially the third stage. I'm getting wonky, but the technical edition, the 2015 edition that Don certifies, have to be on a certified platform in 2019. And the proposed rule for hospital reimbursement says no delays, we're doing it. So my point is, Apple's one piece to get the system thinking in a different way, because it kind of made news, but the undergirding is that the regulations mandate it. And so it was voluntary in December of 16 when Epic loaded out their software, and people could have turned it on if they wanted to, but now it's mandated. So my sense is that you're going to see a huge adoption curve in the short run. But here's the more fundamental point. In my opinion, the voice that Apple represents is really a voice for any application that will help our family members make sense of the data. So it's not just about moving a bit from A to B, it's understanding context and everything else. So the bigger number to look for, Cliff, is the following. Over 400 app developers are in line to connect to the CMS Blue Button API, which is a related but different Fire API. And that includes 23andMe, that includes a whole bunch of other Silicon Valley awesome people. And what that means is my parents both are on Medicare. They will have a marketplace of apps competing to help them make use of the Medicare claims data as one example. And once they start doing that, each and every one of those apps will come right knocking on Dennis's door at Stanford Children's, and he'll ask the staff, do we information block these people? Do we allow them in? And that's the conversation that's going to come. And either the health systems are going to wait for this marketplace to come at them, or they're going to embrace this and encourage it and see it integrated into the physician workflow. And that's going to be the separation between those who are getting it and driving it, or witnessing it and having it come to them. And that's, I think, the moment. Now, Dennis, do you want to react to this? How you want to drive this internally at Children's?
I'm all for it.
But I think it's also important to recognize, though, the fact that it had to be mandated, right? I mean, it means that it's not being demanded by the market, right? That we feel like we need to say in a regulatory framework to vendors, you must provide this, right? And I think that's the dynamic that we need to be revisiting, right?
But here's the irony. It was only for Medicare also. I mean, I'm hoping, like you said, that that's cracking open the door.
It will.
Right? But the mandate isn't necessarily there for Medicaid and for all the rest of the commercial coverage.
Jess, we got work to do. We
have job security, but I'm just saying, like, I think there's an important lever that we keep coming back to, which is the balance between technology and innovation, and where government regulation has some power to spur it, or financial incentive.
Here's the quick irony. Take what Julia just said, take it to Rishi's comments, where he said, hey, we signed this advocate deal a decade ago, and it made the business case for us to stitch all these systems together. Now, let's do a forensic audit. Let's figure out exactly how much money Rishi spent stitching together non-standards-based data feeds, normalizing it, data warehousing, manipulating population health analytics. It ain't cheap. Now imagine he rebuilt that entire infrastructure in 2018 using the technical standards that undergird what you saw with this Fire API. And even better, what Don is talking about with the population health use case, which is being developed right now. My humble opinion is that that is 90 to 95% cheaper when we move to standards-based. Because how much does Apple pay the hospitals to connect to the data? Zero. How much do the patients pay Apple to access the feature? Zero. How much do the hospitals pay their vendor to enable Apple? Zero, if they're on certified technology. So that's the question. It should be in their interest, Julia, and for some reason, it's not happening at scale.
So the name of this session is called Unleashing Data to Transform Healthcare. And I want to talk just a little bit riff on the last session with the population health. There was an interesting study in Cell last month. Some Columbia University researchers, they took 5.5 million anonymized EHRs, and they used an algorithm to connect them to presumed family members using the emergency contacts. And then what they did is they took another algorithm to see if they could suss out diseases that had a heritable nature, that there was some family connection in these diseases. And it's a really interesting study, not much in terms of definitive discovery, but the idea was, sinus infections apparently have a familial component, who knew? But what's interesting is if it brings up Judy Murphy's comment before about the fact that if we can connect EHRs to the other data systems, genomics, all of the other peripheral systems, data systems we have, imagine what we could unleash in terms of data. What's stopping us from doing this?
So I want to take that directly back to what Rishi said. So what's stopping us from doing that is we protect the data to prevent bad things from happening to the people who are in the data. So the privacy people read that study and went, oh my God, that is so creepy. Don't be creepy, right? We protect substance use disorder data because we discriminate against drug addicts. We protect mental health data, especially because we discriminate against people who are mentally ill. We protect other characteristics that are mutable or health-oriented because we've chosen to protect the data instead of protecting the people. And so to Rishi's comment, if we are really going to learn from this data, we have to figure out how to strike a different balance. And in some, probably many of the people in the room read that New York Times article from the magazine 2 weeks ago where the physician's practice is sitting and talking with the patient, right? That builds the trust so that the patient will take advantage of the system that's in place, which is the data should be used for health, and it shouldn't be used to make bad stuff happen to you in your job, in your retail, in your credit rating, in your mortgage, with your marriage, with your children, whatever it is, right? And so that is actually how we unleash the data, is by rebuilding the trust of the people whose data that is. I would not want somebody to make genomic deductions about my family because of my cell phone or my Facebook post or any of that. By the way, Facebook thinks I'm African American, so they totally need to work on their algorithms.
So, I mean, bringing up Facebook, Julia, one of the things we've learned is what happens when there is a blow to trust in the companies that hold our data. How much has this hurt this sense of the value of EHRs?
I mean, I don't think we've had that blow to trust. I think we are constantly anticipating it and then acting as if it's going to happen. And I mean, I completely agree with Lucia. I just think our framing around this has been all wrong. And what we need to see is the risk of not sharing the data, not connecting the data, instead of having this hypothetical fear of the bad things that will happen when we do.
So,
I was going to say, it's interesting news to watch. So, eClinicalWorks got in trouble. They weren't interoperating, blah, blah, blah. There's a civil lawsuit against eClinicalWorks for $1 billion because they didn't exchange data. And a guy has articulated a class saying, you didn't exchange about me, and I had all these things happen because my data wasn't available at the next place in the system. And I've been waiting for this lawsuit for many years, and I think eventually, in fact, the medical standard of care will be to exchange. To Julia's point, we're not there yet. But if the data is there waiting for you and you could get it easily without special effort, and you don't, just think about that for a second.
So, we are so used. I love the example before, I think it was Taylor that talked about the fact that, pilots trust their computer systems and they're up there. I was talking with Lloyd before, Dean Miner, and he said that, ATM machines around the world, what do you trust more than, what sort of obligation is greater in terms of trust than protecting your bank account, for a lot of people. And so internationally, we have a system of protocols, of standards in which any bank, any ATM machine in the world, you can go to and get your, with a 4-digit or 6-digit PIN code. I mean, why is it so, what is holding back on the standard side?
So I think Julia's right that we've had a compliance and not a strategy approach to privacy and security. I won't bore you with the details. When
Please.
ONC launched the open API, the first thing we heard was it's not private and it's not secure. And so we did a 9-month project to explain through public meetings and white papers about, in fact, it was just as secure as all the other APIs you are all using right now to tweet. Or whatever you're doing instead of listening to us. It's all the same technology. And so the technology for that is out there. And we cannot stop bad guys. And to your point, in Guatemala, you will never want to use an ATM because they're all compromised. At least that's what I hear. So it kind of depends on the country.
So leaving
Venezuela,
Guatemala out or wherever
they're
it is.
Bad guys.
Let's just, okay.
We can't stop the bad guys, but we don't stop driving just because we might get in an accident.
Well, let me friendly amendment on this, just if I may. username and password access to portals where you can pull in your medical records are far worse, security-wise, than an API. Let me just clarify this. This is a weird example where modernizing makes us more secure, not less. And let me clarify. By the way, health is not a vacuum. We did open API work in energy, financial services, by the way, all regulated. So in California, we're in California, Northern California, PG&E installed all those smart meters. You have today in Northern California the ability to connect a solar panel maker's app to your smart meter in the same technical approach that we're talking about that allowed that Apple Health to work. It's basically OAuth internet standard. Here's the issue. When we opened up the most popular government data set around these topics, it was the IRS Get transcript. We allowed every American to download 3 years of their tax filing history in a machine-readable format. 23 million Americans logged in and downloaded the transcript. But Cliff, a good chunk of them had their usernames and passwords compromised by shady people. So to the IRS, they came in right through the front door. But in reality, they were stolen credentials. And because there's no, the systems were not upgraded in terms of the API, there's no way of knowing what was the machine that was logging in. What the APIs do is you register, the consumer is authorizing a machine to talk to your EHR. So if I authorize the machine built by IBM that Paul made awesome, and it's working from a server farm in North Carolina, and then one day it switches to a server farm from China, the machine, the folks at Dennis's shop would automatically know to cut off access because they noticed an anomaly. By the way, this is how global internet APIs work. So modernizing is critical for the security debate. And whatever reason, we keep getting stuck and we can't. So in my humble opinion, the opportunity in front of us right now is to basically say the fundamental principle, and this is my final comment, I'll let you go. I think we're in a transition like the pension plans to 401ks, where I'm democratizing. I may not want to log into my patient portal and look at my statistics because whatever, what does it mean to me? But I would love to authorize a 401k like what we're calling a health information fiduciary that can store all of my information and help provide me the decision support to navigate through the delivery system. I think that future is coming. That's not Apple or Google or whatever. That could be a new Fidelity. I don't know who it is, Walmart, whatever. Someone is going to help construct that. And the foundation is being laid now, Cliff, that that's possible. And I want to just see that we continue to build on that progress.
Okay, we got 2 minutes left. I want to go through each of you. And since I want to have you both all think about 3 words, disruption. So 10 years ago, the continuous glucose monitor was invented. You have the smartphone invented. You connect the two, and suddenly you actually change lives. Tell me what you would connect to EHR. What new in your hatchery, Anish? What are we looking for to really change lives as briefly as you can? And let's go through each one of you.
Start with Julia.
Okay, Julia.
So I would say the life that I care about, my social life, my family, my friends. I mean, if you're going to change my behavior, I mean, that's what you need to get to. And so I think you need to connect my health data to my life. And that's, those are the people who I care about, whose opinions are going to actually result in my changing something.
Great. Jess?
So I think the reason we're one of the sickest countries in the world actually doesn't have to do with the lack of a widget here and a wonk there. I actually think it's because of lifestyle. And so the social determinant issues that Rishi summarized so well in the end. And so I would bring that in, and not as a nice to have, not as an ancillary, not as something you have to do a study to find out. But if you're my mom who has cancer and lives in a rural area and you're going to prescribe her a daily regimen of chemo and you didn't ever ask where she lives, which is 100 miles away each way, then shame on you for your oncology practice.
Mm-hmm. Great. Jess?
I think it's a combination of easily acquired caregiver credentials so the caregivers can communicate with the providers, and the universal CAMP medical record form app.
Oh, yeah.
Right? Because my kids are now grown, but there was a time when it was 24 pieces of paper all with the same information and the boxes in different places every summer. So if you really want to move the needle, the really sick people need a lot, but a lot of people need a little, and that's that universal CAMP app.
Dennis?
I'm going to go back to what Julia suggested, and that is connect my life to my healthcare record, but do it in such a way that I have a basic key that I can go into any healthcare provider anywhere in the United States or in the world for that matter, and just with that key, they know all about me and my health.
And with that, I want to thank my terrific panel. Thank you all. Fantastic. That was awesome. Thank you all.
All right.
We're just going to bring up Lloyd again. Dean Meyer, the stage is yours.
All right. Thank you so much. That was great.
Thanks very much.
Sorry. Thanks a lot. Great. Thank you. Thanks a lot. Good to see you. Great. Well, we started out today saying we didn't want to blame anyone in specific, and I'm pleased that we didn't. We blamed everyone. And that's the way it should be, isn't it? There's a lot we can all do. It's going to take us a bit to digest all the great ideas that came out from the discussions in these panels today, but we will do that. And as I said at the beginning, we will produce a white paper that will summarize these ideas and perhaps also, we hope, give us a roadmap for next steps so that when we reconvene a few years from now, we'll be able to look back on today and say, because of the collective work of all of you and the people you'll be working with, that we've really made a difference. And that is that we're able to unlock the data that is in electronic health records today, and by opening it, make it available for the types of AI, machine learning-based applications that are going to help us really get the information embedded within the data. And in so doing, transform the delivery of care to a much more value-based enterprise than it is today. And also that EMRs, EHRs, rather than being something that pulls providers away from patients, that they become the type of levers and tools that enable us actually to engage more effectively with patients because they present information in a way that can be used readily and added to by both providers and by patients. So thank you all for being here. 2 housekeeping details. Lunch is served in the foyer, and please stick around for lunch and visit and exchange ideas. For those of you who are participating in the afternoon session, we'll reconvene at 2 p.m. in room C of Berg Hall, which is just next door. Thanks a lot. Safe travels.